Hello again, and thank you all for joining us today for the Future of Digital Health for Ending TB, a virtual forum. My name is Alex Moran. I'm a technical advisor for data analytics at URC and work with the TB Care 2 project. I'll be your moderator for the event both today and tomorrow. We look forward to welcoming you today and tomorrow for an engaging set of presentations and speakers who will describe the landscape of digital health for ending TB, innovations in the public and private sector, and thoughts on the future of digital health for ending TB, especially in the context of the COVID-19 pandemic. Before we get started, we'd like to note that attendees will be set to mute, so if you have a question for a presenter, please do leave it in the Q&A section. There's time after presentations. We will open the discussion to Q&A using audio or through the text function, but in any case, we will aim to send responses to all the questions we did not get to in the coming days. So please do feel free to ask questions, even if we don't manage to answer all of them live. If you're having any technical difficulties, please send a message privately to Noberto Polanco or Sharanya Joshi using the Zoom chat function, and the tech team will help sort everything out if you're having an issue. I'd like to note that we'll have simultaneous interpretation available for Russian. If you'd like to use this, please navigate to the interpretation icon at the bottom of your screen and switch from English to Russian. Finally, we'd like to mention that we have a variety of poster presentations and other resources on the website to supplement all the talks we'll hear today and tomorrow. These are available using the poster wall link, and we'll be able to put that in the chat as well. So without further ado, I would like to introduce Hala Jassim-Al-Moussaoui to introduce the forum's objectives and to set the context for the event. Hala is the acting director for the TB Care 2 project and is the vice president for program implementation and business development at URC.
Thank you, Alex. Good morning, good afternoon, good evening, ladies and gentlemen. Thank you for joining us today for this forum, which seeks to highlight digital health technologies implemented throughout the TB cascade of care, not only to maintain essential TB services, but also to improve TB outcomes. It's an honor for me to introduce our keynote speakers who are joining to provide the opening remarks. It's with deep pride that I introduce Paul Mahana, who is the director of the Office of Infectious Disease in the Global Health Bureau of USA. Paul has worked extensively in the development sector, having served as the deputy director of the health office in USAID South Africa and as the chief of the strategic planning, evaluation and reporting division at USAID. Thank you. Paul, the stage is yours.
Okay, so I tried to start my video. I don't know if this is expected to be on video, but anyway, you have a very old picture of me, which is flattering. So anyway, good morning, everyone, and welcome. It's an honor to be here this morning with you all. I see we have a large participation, and I'm thrilled to be here this morning. It's a real honor for me. And thank you, Hala. It's great to hear your voice, and it's great to be here. So thank you, TB Care 2 team, for putting together this important event on the future of digital health for ending tuberculosis. As we have all experienced, perhaps more than ever, digital solutions are critical in all aspects of life, including the global TB response. TB remains an urgent public health threat and a leading infectious cause of death worldwide. The deadly disease takes the lives of an estimated 1.5 million people each year, more than HIV and malaria combined. The United States Agency for International Development, known as USAID, leads the US government's global TB efforts by working with agencies and partners around the world to reach every person with TB, cure those in need of treatment, and prevent the spread of new infection. USAID continues to lead the global efforts to end TB. In 2018, the UN General Assembly high-level meeting on TB, USAID launched the Global Accelerator to End TB. Alongside heads of state from high TB burden countries, we committed to reaching the ambitious target of enrolling 40 million people on TB treatment by 2022. With the accelerator as the business model to help build countries' commitment and capacity to get there. Designed to increase investments from the public and private sectors, the accelerator aligns with local communities and partners to deliver performance-based results towards the global targets. The accelerator remains increasingly relevant because it strengthens local institutions and promotes systemic change in the health sector, both crucial to countries maintaining progress to date in addressing TB. As the world comes together to tackle COVID-19, it is important to continue to protect the lives of people with TB and not see the reversal of our investments. Recent modeling studies that have been done cite that due to COVID-19's global impact, a minimum of 5 years progress could be lost, with global TB incidence and deaths increasing to levels not seen since 2013 to 2016. With this, we cannot continue business as usual. It is critical to continue to innovate and adapt programs to aggressively address TB. The future of digital health and technology, especially in high TB burden countries, offers hope as we endure the current public health crisis of COVID-19 as a global community. I look forward to this morning's timely discussion on technologies that will serve as vital tools in the fight against infectious diseases that threaten stability across the globe. The USAID TB Care 2 project has worked in close cooperation with local governments and international partners to improve TB prevention, detection, and treatment in over 15 countries. As you will hear, digital technologies have been key interventions in these efforts. The past 5 years have shown us how immensely powerful technological health interventions can be. In April 2020, USAID released its first ever digital strategy, charting an agency-wide vision for development and humanitarian assistance in the world's rapidly evolving digital landscape. We are proud to invest in digital health through our programs and continue to roll out new technologies. For example, using the TB Star app in Nigeria has enabled providers to report TB service delivery data and monitor performance in real time, which has been critical in maintaining TB services during COVID-19 movement restrictions. I am pleased to open this important forum today and look forward to this event. Thank you for taking the time to engage on such an important topic and for your dedication to ending TB. Thank you all and best of luck in this forum. Hala, back to you. Thank you.
Thank you very much, Paul. It is a great pleasure that I introduce URC's President, Errol Gast. Errol brings 30 years of experience in government and private industry, leading strategic, results-driven programming and implementation, and having previously served as the Assistant Administrator for the USAID Africa Bureau and having worked in the private sector as well. Errol, the floor is yours. Thank you.
Good morning, good afternoon, and good evening, everyone. And thank you, Hala, for the introduction. I'm going to try and turn my video on since I did wear a suit and tie today, and it says it cannot work. So like Paul, I will be resigned to just having my face on the screen. And Paul, it was great to see you, even though you admitted that that was an earlier picture of you. Welcome to this virtual knowledge sharing forum that will contribute to an already existing robust conversation on TB detection, prevention, and treatment. Understanding the gravity of the TB epidemic back in 1993, the World Health Organization declared a global TB emergency, calling on national governments, international organizations, and leaders from around the world to act. Since then, USAID, in partnership with national governments, civil society organizations, and the private sector, has saved more than 58 million lives, implementing evidence-based TB interventions and programming. There remain many steep hurdles to cross before we reach a TB-free world, but as we collectively continue to develop and apply new digital health technologies, we will be closer to achieving that vision. Today, we are expecting to have about 1,000 participants. I see we're under that number right now, but as the day goes on, I'm sure more will be joining us, who represent more than 60 countries, and all of them are answering the call to action. Over the next 2 days, we will have the opportunity to hear from national TB programs, donors, academics, the private sector, and other experts. We know that success of our shared vision depends on both a moral and scientific imperative to share knowledge, information, and best practices that come from a diverse range of stakeholders. Through participation in this forum, we have decided to take action in the fight against TB. We come as equal partners who are here to share expertise that will help shape our decision making. Over the last decade, URC has had the privilege of implementing USAID's TB Care 2 project. Thank you, USAID, during which we worked with national TB programs and other TB stakeholders to develop and scale up digital solutions to control TB and MDR TB. Globally, the project has implemented more than 54 multi-year activities to control and prevent the spread of TB and MDR TB. All good things come to an end, sadly, and so that is the case for this project. As the TB Care 2 project concludes later this month, we hope that through this forum and other activities, there will continue to be the same level of collaboration that led to significant developments in digital health technologies. This information will take us one step closer towards achieving our shared vision of ending TB. Indeed, some of the most successful aspects of the TB Care 2 project have been in development and institutionalization of various digital health technology. Paul mentioned the TB Star in Nigeria. I'm going to talk about the Connect TB mobile app that was introduced into community-based MDR TB programs in Bangladesh and South Africa. As a result, the application increased retention rates to 90 to 100%. Later, an assessment conducted in South Africa found that Connect TB was the most cost-effective patient management solution at just $76 per person. That's just 10% of what it was costing through the traditional community-based TB programs. As we adjust to our new COVID reality, where Zoom calls such as this become the norm, we should pause and reflect on the technological advancements that have made global collaboration possible during this time. While I'm sure many of us would have preferred to meet in person today, the accessibility of this conference has made it possible to connect with a multitude of experts who share a common vision, a world free of TB. Thank you to USAID for sponsoring this collaborative event, and thank you all for participating in this forum. Back to you, Hala.
Thank you, Earl. Thank you so much. I'm sorry for the issues with the video. I think Norberto is looking at this this issue now. Next, it's with a pleasure to virtual introduce and to be joined by Dennis Falzon from the World Health Organization. Dennis is a medical officer with the Global TB Program of the World Health Organization in Geneva. He has worked extensively in TB and having coordinated the Euro TB surveillance project in Paris and worked in DR TB surveillance and program management in Central Asia. So we'll have Dennis join us via video recording.
Greetings from Geneva, Switzerland. My name is Dennis Falzon and I work at the Global TB Program of the World Health Organization. Thank you for inviting WHO to contribute some opening remarks to your virtual forum on digital technologies in support of TB prevention and care in the COVID-19 context. I start with this broad classification that you have probably seen before, with the 4 functions in which we position the contribution of different digital technologies to TB program efforts, namely patient care, management, surveillance, and e-learning. A number of products could of course serve more than one of these functions. Often, the same staff and same frontline locations managing TB are being solicited to handle COVID-19. Digital technologies for TB are thus being roped into the COVID-19 response. For instance, TB medication adherence technologies can also be used to communicate with COVID-19 patients and their households. Test results for TB and SARS-CoV-2 virus may be transmitted to the requester by one connected system linked to molecular diagnostic platforms that analyze both conditions. Data collection for the TB contact investigation use case presents opportunities to capture COVID-19 tracing activities too. And e-learning courses on TB for healthcare workers could more easily be extended to cover also the needs for COVID-19 than creating new resources. Among the profusion of articles that are being published daily on COVID-19, a few have actually focused on the use to date of digital technologies and explored potential uses. Despite the adversities brought about by the pandemic, some authors have posited that we are at the cusp of an exciting era in the maturation of digital technologies to overcome clinical problems and diseases. Emerging concepts like artificial intelligence, the Internet of Things, big data, and blockchain may get the best moment ever to prove their worth in mitigating what is probably the biggest social challenge in living memory. The features of digital tools implemented or under consideration for the COVID-19 response and classifications thereof, such as the one shown here, are revealing of their broader relevance to other conditions like TB. Some of the particularities of this classification include the application of novel analytical techniques for epidemic intelligence, tracking the mobility and localization of patients, use of wearable sensors to monitor body temperature, applying computer-aided diagnostics to medical imaging, and using novel means of communication and retrieving information. Proposals on how to maintain essential services such as TB care during the pandemic have been detailed in this WHO document released last June. Once again, the role of digital technologies would be critical for the monitoring of many essential TB services and during catch-up on activities that were suspended or relaxed when lockdowns were in place or healthcare services overwhelmed with pandemic response. COVID-19 presents us with new challenges on how to continue expanding essential services such as TB care while dealing with the pandemic and seeking synergies in joint action. Many digital technologies used today to support different aspects of TB programs have a direct application for the response to COVID-19. Data need to be collected alongside all investment in innovation. Evidence from trials, implementation research, and other studies on the effectiveness, quality of care, and efficiency at large scale remain critical. And with that, I wish you a very successful meeting, and we meet tomorrow. Thank you. Greetings.
Thank you very much. Alex, back to you.
Thank you, Hala, and thanks to all of our speakers for the context and for all of the thoughts on the meeting today. We very much appreciate it. With that, we'll move to our first presentation session, which focuses on detecting TB with digital health technologies. For this session, I'd like to welcome our two moderators, Kaiser Shen and Zhishen Qin. Dr. Shen is a Senior TB Technical Advisor at USAID Washington, and Dr. Qin is a Senior Technical Officer with TB Reach based in Geneva, Switzerland. I will pass the floor over to you.
Thank you, Alex. And thank you everyone for joining today's session. My name is Jujin. Me and Kaiser will be monitor the first session on detection. And this is, I would say, is very exciting time to talk about digital health solution. As people say, the 21st century is a century of fourth industrial revolution. But healthcare has always been slow in adopting digital technology. But with this ongoing pandemic, COVID-19, we have seen that this produced an opportunity to catapult TB care into the digital future, especially in the context of detecting TB. In this first session, we'll have 3 speakers to share their technology and experience using 2 main type of digital solutions, namely artificial intelligence and health information system in the context of detection. So firstly, it's almost impossible to talk about the future of medicine without stumble across these 2 words, artificial intelligence, AI. These words also bring many hope and fear and confusion to the medical professionals. But AI is not new, but it only gained traction in healthcare in the last decade or so. The very first project when I joined Stop TB on artificial intelligence was back in the early 2010s when we founded the project in Zambia. At that time, the technology was still using feature engineering, machine learning technology. And we have conducted an evaluation study at the end of the project, and a study shown that the traditional AI methods has underperformed experienced reader that we can obtain in the field. However, the changes in technology, in artificial intelligence technology, especially in the year 2012, has really changed the landscape of AI. Since then, we're seeing more and more AI solution, power solution to detect multiple diseases from chest X-rays. Since then, StopTB has piloted and rolled out multiple CAD product, AI product in multiple countries. And some recent studies have shown that some commercially available AI-powered CAD product has outperformed experienced radiologists in Nepal, Cameroon, and Bangladesh, and Pakistan. It's not possible to talk. Can we go to the next slide, please? So while waiting for the next slide to load, I just wanted to give a very quick description of what the modern AI technology is. It uses something called deep neural network. There are a set of algorithms that are organized in nodes and layers that mimics human cognitive function. It is designed to automatically infer rules to recognize pattern. And here is the key, the automatic infer of rule. This neural network has helped us to cluster and classify images and sound and text and time series data after they've been trained with large level of data. Next slide, please. With the advent of the newer AI technology, we have seen an explosion of CAD solution available on the market. The slides show a current landscape study that we have conducted together with FINE to assess the current landscape of CAD solutions that are available or soon to be available for TB. And the sites are freely publicly available to any TB implementer to access, and it provides information on operating information and pricing information and whatnot. So one of the two of the presentation today will be focusing on using artificial intelligence. The first presentation is actually coming from one of the company we're showing here. And before I pass the mic to the first speaker, just some housekeeping. So after each presentation, there will be 2 to 5 minutes to answer question, for the speaker to answer the question. Kaiser and I will be monitoring the chat box. So preferably, if you have any question, please leave them in the chat box and I will read it out to the speaker at the end of the session. With that being said, let me introduce the first speaker, Rishma. She is the head of operation at Cure.ai, and she has years experience in building and scaling up product innovation in healthcare. So Rishma, the floor is yours.
Hi everyone. I once met a lady in a TB case finding camp who recorded her symptoms to be cough over a year. While probing her further, the healthcare worker asked why she didn't seek care for such a long time. She mentioned that she had met a doctor a year ago who advised her to get a chest X-ray done, but she did. But unfortunately, she couldn't travel back miles to collect her report that was ready after a few days and couldn't follow up with her doctor. Instead, she got some medicines from local stores and found a temporary relief to her symptoms. I'll call her Neeta. And Neeta is a part of large demographic of people who either do not have access to early diagnosis or cannot afford quality diagnostics. I'm Reshma. I head operations at Cure.ai. At Cure, we build products and solutions using artificial intelligence techniques, focusing on radiology to enable early detection and diagnosis of diseases such as stroke, COPD, tuberculosis, and now COVID. Today, I will be focusing on how such technological intervention can bridge these underlying gaps through case detection and management using QTrack and QXR. So QXR is an artificial intelligence-based chest X-ray detection software that can identify 29 different findings in an X-ray, which are suggestive of tuberculosis or other lung disorders or critical findings including pneumothorax, rib fractures, etc. Trained with over 3.5 million X-rays and its corresponding reports, it not just identifies these findings, but also localize and highlight the region of abnormality. The TB algorithm of QXR is much optimized for the final confirmatory results, and it can detect the signs of classic as well as atypical pulmonary hilar and pleural tuberculosis. It can integrate very seamlessly with any X-ray machine across CR machines, DX machines, automatically capture these X-rays as and when it is done, process them, and produce the results of signs of tuberculosis, whether it is present or not, within 45 seconds to 1 minute. While working with these programs around the world who are using QXR software for case detection, we understood that while case detection is one aspect, there are also a lot of decentralized process, including symptom screening, gene expert result compilation, presenting all of this to a physician for their confirmation and treatment initiation, etc. So we could see all of these different pieces joining and come together in a single platform, which we built, which is a complete workflow management software called QTrack that tracks the complete journey of a patient from symptom screening, AI-based case detection, bacteriological confirmatory results tracking, and an X-ray viewer for the physician to finally look into it and take an appropriate action. It also has insights and dashboards and analytics to empower the frontline healthcare worker as well as the program manager to improve their operational efficiency. QTrack is web-based application which can be accessed anywhere using secured links and secured protocols. But also, it also has a mobile-based application that can do all of these features. But we also added one feature to the smartphone-based application for capturing analog films and processing analog films for AI-based detection. So we understood that while not all health systems have upgraded or have an upgrade of a digital X-ray machine. So some of them still have analog machines. Secondly, there are patients who are coming from probably carrying their old X-ray films for a follow-up, or coming with an X-ray that has been taken very recently from a different site and so on. So what QTrack web-based workflow does for analog films is that while apart from all of these other features that I have mentioned about, it also captures the picture of a X-ray film and also produces the results of any signs of tuberculosis instantaneously with the mobile application. Now, this results can also be merged back into the web-based workflow, and that can also be viewed separately as well. We also added a AI-aided sputum pooling process. What it does is it combines the chest X-ray score by the software, looking at the risk of the tuberculosis from these chest X-rays, and provides a guided process for the lab technician to group the samples and then run the expert test or the final bacteriological confirmatory test. Now, this enables a significant reduction in the number of cartridges that are finally used in identification of the cases. And this is currently a proprietary and a patented AI algorithm that can be part of the QTrack workflow as well. Prestigious institutions like StopTB Partnership, McGill, MGH have validated the QXR software. But I would like to highlight the most recent validation and paper that has been published by StopTB Partnership, which is the largest data set to date, about 23,000 data or patients' data from Bangladesh. And they compared multiple AI and CAD algorithms to with GeneXpert as the final confirmatory results, and compared the softwares as well as a human reader to the ground truth. Now, the results shows that all the AI or CAD algorithms have performed better in terms of sensitivity and specificity than the final confirmatory result. And out of the 5 different algorithms, QXR had performed better in terms of AUC across all the different algorithms that has been compared. They also have done some very interesting analysis on the percentage of the expert cartridges that could be saved using these AI algorithms in a program workflow. And interestingly, QXR could save the highest because of the increased specificity of the software. The highest savings that has been seen with QXR, about 64% that has been noted. We've been working with many projects, demonstrated many successful projects that have been either funded by Global Fund, USAID, TB Reach, Wellcome Trust, etc. And it's also part of multiple scale-up proposals as we speak. And the software is completely hardware agnostic. It can work with any X-ray machine, CR systems, DX systems, any of those. And currently we can go live in less than a day, including deployment and training the different stakeholders out there. We also do a sensitization of a complete AI algorithm and what goes in that AI algorithm before we start off if need be. Currently, there is a prompt customer support, and then we support the projects throughout their life cycle. The Find has been evaluating multiple AI algorithms, and currently the evaluation has been completed and the data has been presented to the WHO to take a decision on further endorsement. What we have learned working with the different programs who have been using QXR and QTrack over the last few years is that there is a direct and an indirect impact of using the software in the program workflow. One being the increase in case notifications, especially when it comes to asymptomatic cases. The software can pick up even the slightest findings from the very subtle findings from the X-ray. Second is because of the reduced turnaround time, now the bacteriological confirmation and treatment initiation can happen probably within few hours or the same day or maximum the next day. Third is the cost efficiency in itself, like I have mentioned in the previous slides. Fourth is the improvement in the patient experience. So now they are more aware of their condition or can understand if they want to be more precautious when in protecting their family members and the people around them. I would like to substantiate this with picking 2 different programs that we have been working with. I've picked up one which is Philippine Business for Social Progress in Philippines. This is a Global Fund grantee. We've been working with them for past 2 years. Now here we have, they have mobile vans which go into communities for active case finding activity. And we have reduced their X-ray interpretation time from 3 weeks to 1 minute, significantly reducing their loss to follow-up cases. So by the time those cases, while the clients, they take the X-ray and they are out of the mobile van, the healthcare worker knows whether their sputum needs to be collected or not, and the process happen immediately. And with a combination of all of this, the sensitivity and the reduced turnaround time, etc., there has been an additional 11% cases that has been detected by the software, which would have been missed otherwise using traditional methodology that we've had, and also ensure 100% sputum collection. The second story that I would like to highlight is with PATH, a project that we have demonstrated in India, in Maharashtra, which is a linkage between the private provider and public sector. So the QXR software was deployed in these private clinics, and the workflow management tool QTrack has been used by the program in themselves. Whenever the software picked up any case that had sign of tuberculosis, it immediately sent text-based alerts to the healthcare worker, who then got in touch with the patient immediately for sputum collection and further confirmatory results. Overall, the program impact has shown there is a 20% increase in the case notification with the improvement in the microbiological confirmation percentage, of which 13% increase in the case detection has been attributed to using QXR, who would have been missed otherwise if the software was not used. In addition to QXR and QTrack, we also build a platform for remotely monitoring those who are at risk using chatbots. That and case detection and case management algorithms, all of this coming together, we envision a positive shift in the TB care workflow that is existing. Currently, our products have been deployed in about 28 countries. We process over 10,000 different scans a day. We will continue to understand, learn these challenges and pain points, and improve these software and build these software to provide quality healthcare, affordable and accessible to everybody in the world. Thank you very much, and I would like to take any questions that follows.
Thank you very much, Rishma. Now we're open for question. I see that there is one question on the chat has been already addressed. Is QSR being used in India? The answer is yes. There's another question. Let me read it out loud. Can I ask how research were designed, conducted, and then presented here? Was it done by the company or elsewhere? How valid are they?
Hello. Hi, can you hear me?
Yes.
Hi, everyone.
Yes.
I can actually answer the first question, whether it is used in India, very briefly. Yes, it is used in India. We are currently working with government as well as non-government organizations, and not for both public health and as well as private sector. I will take the other question. So we've been working on this software or the algorithm or the platforms for the past 5 years. And so if you want to know how we designed the AI, or if you can make the question a little bit more specific, probably I can answer accordingly.
Yeah, so Rishma, so I think the question is more around the validation study. How were those studies designed and conducted? And was it done by company or done by other people, other groups, and how valid they are?
Okay, sure. So QXR as a platform, there has been many validation studies that have been conducted internally as well as externally, but specific to TB, we do have about 4 publications, and the most valid 2 publications that have come out, and where Stop TB Partnership have published 2 papers, where Region is the author, and one of which was with the data from Nepal and Cameroon, and the second was with the data that I have shown on the slide, which is about 23,000 data set from Bangladesh. The first one is published in Nature Scientific Report. The second one is currently under publication. And apart from this, we also do have many other publications, not specific to TB, but also for the other findings, which are also suggestive of TB in PLOS1 and other publications as well.
Thank you so much. And I think there are many questions around study design, which we can share the publication link with the participant later. Maybe that will be more detailed. Let me move on to the next question. I think that's the last 2 we can take. The next one is how many countries is this being used in subcontinent, and does it include Pakistan?
Yes, it does. So we are actually working with in this hospital. They are using our software for both TB plus COVID use case right now in their vans. So we have already processed over 30,000 scans with them. Yeah, so it is being used in Pakistan.
Let's try if we can take to other. Are there any WHO recommendation for the use of such program?
As of now, no, but FIND has already completed their evaluation. The results have been presented to WHO. Currently, we are waiting for the results or for the decision on endorsement from them.
Great. And the last question is more around the challenges. What are the hindering factors in scaling up the use of AI technology in detecting TB in high-burden country?
I think for us, what we had seen is that in some of the settings where we are working with, initially we worked only with a cloud-based processing method so that we could give much more capability of the software, and especially the Q-track workflow where there is a program manager who can oversee the entire activity that is happening on the ground. But the internet connectivity had been an issue in the past, but we also do have an offline solution to now mitigate that those issues. Apart from that, we also feel that some of these regulatory aspects around this. So every country that we will be working with, we need to get our product registered. We do have a CE certification, but every country also need their individual certification process. Like for example, Indonesia or Vietnam, any country that we talk about. So that will be a little bit, it's not a real challenge or challenge per se. It will take a little bit of time to get those certifications in place, maybe in a matter of few months. That's about it.
Thank you, Rishman, and thank you everyone for asking questions. I see there's still some questions coming up on the chat box, but we have to move on to the next presentation. But Kaiser and I will be taking notes of all the questions in the chat box, and we'll try to compile it at the end and send it to the presenter. With that being said, without further ado, let me introduce the next speaker. I hope I pronounced your name correctly, Vaishnavi. She is the operation manager of PASS India TB HIV program. She is currently working on multiple private sector engagement projects on TB, such as the PPIA project, Challenge TB, and the TB Reach Wave 6 projects. Now, Vaishnavi, the floor is yours.
Hello everyone, good morning, good afternoon and good evening. My name is Vaishnavi Jundhale and I work as an operations manager with PASS India's TB HIV group. Today I will be talking about our intervention on inclusion of artificial intelligence for chest X-ray screening in India in the private sector. The technology that was used for the intervention was QXR by QRAI. The cloud-based AI software QXR was used to detect abnormalities in chest X-rays such as pleural effusion, calcification, consolidation. Combination of 8 of these abnormalities is used for TB screening through QXR. The intervention was funded through Stop TB's TB Reach Wave 6 with the focus on slum populations in Nagpur. Nagpur is one of the top 20 cities with high TB burden in India. The intervention was implemented in 6 TB units of Nagpur, starting with mapping and then engaging with 430 informal providers from the private sector who were willing to participate in the project. These informal providers could provide free chest X-ray vouchers to their coughing patients to ensure screening for TB. The project also engaged with 6 private sector digital chest X-ray labs. Presumptive TB patients could get their chest X-ray done at these labs free of cost. As explained in the flowchart, the presumptive TB patient's chest X-ray was screened using QXR as well as by the radiologists. For any presumptive TB patients with abnormal chest X-ray findings on AI or by the radiologist, sputum sample was collected for microbiological confirmation of their diagnosis using TrueLab test. 8,303 patients were screened using QXR and radiology. Out of these 8,303 patients, 2,371 patients had abnormal chest X-ray findings through AI or radiologists or both. There was a concordance of 82% reported between QXR and radiologists' screening results. 224 TB patients were detected through the project. QXR accounted for 13%, that is 29 additional TB patients who would have been missed in the absence of AI. The requirements for the software at the digital chest X-ray labs are listed in this slide. Windows 7 with Service Pack 2 or higher along with 10 GB free space is required for installation. If the lab does not have internet or allow internet access on the machine where chest X-ray images are stored, there is a requirement of LAN with a second machine having internet access. Static IP address is required for both these machines and needs to be communicated to the AI team. As the project was implemented in Nagpur, the QRAI team did installations and applications upgradation using remote access. So it is essential that the AI team has admin rights and remote access to these machines. DICOM Viewer application KPAX is used for recognizing the .dic and .dcm images which are transferred to the cloud for AI screening. Introducing AI screening in resource-constrained peri-urban settings where there is a dearth of radiologists can be beneficial. PATH contributed to the National Strategic Plan of India and Joint Monitoring Mission in 2019 to include AI-based reading as a part of the algorithm for TB detection. Also, state governments are exploring this pathway to enhance TB screening and detection. PATH is currently implementing QXR in private sector in Myanmar, funded through Stop TB's TB Reach Wave 7. In the current pandemic situation, PATH and PATH's local affiliate in India, CHRI, developed a concept note on leveraging AI to reduce backlog of missing TB cases in India due to COVID-19. As a result, the Global Fund has approved AI-based screening to be implemented in some districts of Uttar Pradesh through joint efforts of Elimination for TB Control or JEET project. Thank you everyone for patiently listening to this presentation.
Thank you very much, Vaishnavi. Let me give people some time to pop in their question in the chat box. I'll take this opportunity to ask the first question. Since you have extensive experience implementing CAS solution, so I wonder if you can share with us on what's the level of training required to implement AI solution for chest X-ray.
Yeah, so to begin with, because there was availability of one QXR or QRAI team's member in Nagpur for installation, that was super helpful, but that was just for few labs, or I should say just 2 or 3 labs. One good thing that happened during the implementation is one of our sputum collection and transportation agent, who's a tech-savvy person, acquired all the knowledge, and he was one of the key members to ensure the installations or upgradation of QRAI wherever it was required when the QRAI team took the remote access and updated the software. So yeah, once things are the installation is done and the software is installed, I think updates does not take time, but in the initial months we did have some hiccups, and this was our first experience in private sector labs to go through the whole process of installation of this the technology as well as the other requirements that were listed. Thank you.
Thank you. Yeah, thank you very much. Another question is more on the diagnostic algorithm of the project. Is the field worker the one who decides on sputum collection without any physician interpretation?
Yes, so the field worker had the access to all the results of QRAI who had abnormal findings. So they used to get the message from the application of any patient whose chest X-ray was abnormal, and then they used to coordinate with the informal provider to get the sputum collected and from the patient. So the communication point was the informal provider, but the access of the results was to the field worker to understand if there is abnormality in the chest X-ray and then do the next actions.
Thank you very much. And the next question is, how did you sell the idea of using AI to private sector? Aren't there any apprehensions using AI might take away their job and their income?
So there were certain, I should say, communication or information sharing requirements with the Radiology Association in Nagpur to ensure that they were onboarded, but it took time. So yeah, the learning from the intervention would be to have all the relevant stakeholders onboarded in the beginning or before even the intervention starts to have that buying. And yeah, I mean, it took some time for us to get to the Nagpur Radiology Association been convinced on the AI implementation. From the software perspective, or whether we should include AI in private sector, that is a definite yes. The requirements are now much more clear, and as Reshma also mentioned, there are a lot of changes that have happened over the year as well from the technology as well.
Thank you. The last question is, did the private provider keep using QXR after the project ended?
No, so because the Stop TB interventions are the 18 months intervention, this did not continue. Unfortunately, we were trying to have this conversation with the local government. Unfortunately, the funding was not available. But nevertheless, there are the information is because of this pilot, information is passed on, and as I mentioned, it is passed on to the national TB program, as well as there are other opportunities happening with the GEAT project. So we are just the WHO endorsement would also help. So yeah, there would be, I'm sure AI would be used in the future for especially peri-urban and even rural geographies for with any offline mechanism available.
Thank you very much for your presentation and all your response. For the interest of time, I saw a lot of interesting questions, but we have to move on to the next and final presentation of this section. With that, I'll introduce my co-moderator, Kaiser Shen, to introduce the final speaker. Hello, Kaiser.
Can you hear me now?
Yes.
Hello? Great. All right,
yes.
I'm on my phone, so I realized I was shifting between my screens. All right, sorry, I apologize. So I have the pleasure of introducing the third and final session today. Anna Fruhoff is a public health professional and project owner of the ETB project for Doctors of Madagascar, She's worked many years in infectious disease as well as community-based programming with Partners in Health in Sierra Leone, as well as with WHO in Switzerland. Anna started her graduate medical degree in Germany, and she works as a freelancer supporting doctors from Madagascar with all the ETB-related programmatic design and research activities. So Anna today will share with us about the adaptation of Mtomari, a digital health financing platform that was designed for secure exchange of healthcare payments in Madagascar, and how it's translated to a digital health intervention for TB case management. So with that, I'll hand it over to the moderators.
Hello everyone, my name is Anna Frujauf, and on behalf of the Doctors from Madagascar and Mtomari teams, I'm excited to present today on our plan of scaling up an integrated data collection and finance tool for TB care provision in Madagascar. The tool is called ETB. The ETB project develops out of an existing tool called Mtomari, which is a digital health financing platform that patients in Madagascar currently use to save for future health expenditures. Patients can then use the tool to pay for health services via mobile money at our partner facilities. This tool is proving to be very popular and successful, so knowing the unique challenges that come with data collection for TB, we decided that we wanted to adapt this tool for TB case management and financial transactions. So the ETB project has 4 main components, all of which developed from the existing Mtomari tool. Firstly, the tool allows us to track patients across the TB care cascade using digital data. What is perhaps unique is that frontline workers collect this data using photo capturing rather than manually inputting the data themselves. Data is then used to create dashboards that can be used for monitoring as well as political decision making. And then lastly, because Mtomari is a digital health financing platform, the tool allows for integration of financial workflows with programmatic TB data. So this can be used for performance-based incentives, but also for mobile money transactions, thus reducing the time that the NTP is currently spending to travel to all facilities in the region to pay facilities relatively small amounts of money. So this gives you an overview of the different components of the tool and how they're being used by different actors. So I was just talking about the financial aspect of the tool, which you can see in the green arrows. As I was mentioning, the NTP can now pay facilities via mobile money, while facilities can hand in expenditure documents using photo capturing. And the same goes for their data, which is again captured using photos. And then you can see on the regional level the dashboards that we're creating. In the long run, we're also hoping that these dashboards and aggregate data will allow for integration with DHIS2. So why do we believe in this idea? I was saying earlier that Mtomari is already a successful and popular tool in Madagascar. So to give you some data behind this, it's the largest digital platform for healthcare-related payments in the country. We've already covered and supported more than 15,000 patients, and we're fully integrated into 38 hospitals and covering over 50,000 health services. At the same time, data for case management and surveillance in TB is an issue. Our internal data suggests that only 40% of facilities have complete and accurate TB registers. At the same time, there is an opportunity for digital interventions. Nowadays, all of TB diagnostic sites have reliable cell networks, and staff are really interested in using digital health tools and also have relatively good digital literacy. So in an internal assessment we did, over 50% of staff reported having previously used tablets, smartphones, and mobile money. So the ETB project will be implemented in one region in the south of Madagascar. This is a very rural region that the NGO Doctors from Madagascar already knows very well, and where the NGO is already actively working. The region has a population of around 1.8 million people and is already seeing quite a few TB cases. However, we believe that we're missing a lot of TB cases. So we believe that this is due both to low case detection, but also loss of TB presumptive cases and TB patients across the TB care cascade. In terms of the TB service structure, there are 22 TB diagnostic sites with 38 TB frontline workers, most of which are lab technicians, as well as 4 NTP staff at the regional level. So in terms of implementation requirements, of course, this project was developed in close collaboration with the National Tuberculosis Program. But in addition to kind of the standard electronic hardware, training, as well as network availability components that are probably inherent and required by any digital interventions, there are 2 requirements that I think are particularly noteworthy from this project. So firstly are SIM cards. Every patient that gets registered as a TB presumptive case and thus gets entered into the tool will receive a SIM card, which we use as a personal identifier. I know that this is a challenge across many projects, so the way we solve this by using SIM cards. And then secondly, I was talking about the fact that frontline workers collect data using photo capturing. So while this is obviously reducing the burden on frontline workers that are meant to perform clinical tasks, this means that we need to hire data clerks that basically spend time inputting the data from the photos into computers. So I want to end this presentation with firstly summarizing what we believe is unique about this project. And then secondly, because we're still in the planning phases, give you an idea of our next steps. So in terms of the uniqueness of the project, I was explaining earlier that frontline workers collect data through photo capturing rather than manually inputting data. Frontline workers are trained in clinical care provision and not necessarily digital or even paper-based data collection. So we believe that photo capturing will improve data collection and completion while reducing the data collection burden for clinical frontline workers that are serving patients. Secondly, we believe that the digital integration of financial and programmatic data aspects of the tool are unique. I think the benefits of having accurate and complete digital TB data across the care cascade for case management, surveillance, and policymaking are clear to many, but the finance aspect of TB is often ignored because TB care is free for patients. However, we believe that integrating a financial component into this tool will not only greatly reduce bureaucratic workload for NTB staff, but also allow for performance-based incentive structures supporting TB case detection, care, and adherence. Lastly, we have the benefit that the ETB project is developing from an existing tool, the M2MADI tool. So this allows us in the short run to build on their successes and lessons learned, and in the long run, allow for horizontal integration with multiple disease areas. So in terms of our next steps, we have adapted the tool for TB care. So the digital component is completed. We have a programmatic management team in Madagascar working on launching implementation. Of course, this is pending the development of COVID-19 in the country, but also globally. But our plan is to basically, starting from October, pilot the tool in a few facilities, then allow for potential adaptation if necessary, and then basically make sure that by January, data collection and syncing is robust so that we can launch the dashboards with the NTP. In terms of the financial component, we will already be using that financial component internally, and once it's working, we'll scale it up with the NTP. Because the idea for this project, if it is successful, is for it to be scaled across the country. All of our implementation will go alongside the development of manuals, robust training materials, and SOPs, allowing for further scale up. So thank you so much for your attention. I really look forward to your questions. And I believe that some of my team members will also be joining the session as participants. So if you have more technical questions, which I cannot answer, they might also be able to help. Thank you.
Great. Thank you, Anna. So we will take a couple of questions from the chat box. Let's start off with the first one being, are there all services included in the program, such as consumables for reagents, medical devices, anti-TB drugs?
Yeah, I think that, can you guys hear me? Sorry.
Yep, we can.
Awesome, great. So I think I'll combine that question with the question on paid services and free services. And I think this is best answered by explaining the transition from mTOMADI to ETB in more detail. So mTOMADI was primarily focused, especially initially, on maternal health, which in Madagascar is not always free. So the idea was that basically patients use the tool to save money that they can then use for their pregnancy journey. So this worked really well, but we were also recognizing that we had issues with TB data collection as well as TB financial transaction, but those regarded transactions from the NTP to facilities. TB care in Madagascar is free for patients. So we basically, now the financial component is not really focused on the patient, but is focused on NTP as well as we use it internally for our operations. So for us, this includes anything from DSA, fuel, really any expenditure that you can imagine.
Great. Sort of along the lines of what I was thinking in terms of catastrophic costs, is it relatively high? It sounds like TB care is covered under and Madagascar is free. Is there plans to integrate with other systems, so other disease programs within a general clinic? Has Madagascar considered these type of integration points?
Yeah. So of course, this is the long-term plan. So mTOMADI started with maternal health. Now we're moving from a more or less paid service to a free service, but still using the digital component for financial transactions. So the idea is that ideally, this will be integrated across disease areas using a very horizontal approach.
Okay, great. So it looks like we are at time, a little bit over, but I'd like to thank all the presenters today at this kickoff session. And we have captured the questions in the chat box, and we will certainly relay any questions that are open-ended that haven't been answered yet. But again, on behalf of myself and Jijin, we would like to thank all the presenters and attendees of this session. And hopefully you guys will stay on for the rest of the day and subsequent day as well. Thank you.
Thanks very much to our moderators and also to all of our speakers. A really engaging session and a great way to kick off the day. I'd like to mention quickly that we will be making the recordings available for both days of the forum, and you'll be able to find that on the forum website. And then also one technical note, we'd ask that you please use the question and answer function for any questions about presentations, and then reserve the chat function for any technical issues or difficulties that will help us sort of compile the questions. And once again, if we didn't get to your question during this session, we'll be happy to send out the responses. We'll coordinate with the speakers to be able to do that, and we'll send out sort of compiled responses to the attendees. And then finally, I think for our moderators and our presenters, we should have fixed the video issue. So if anyone would like to try that, we'd invite you to do so. And with that, I'd like to move to our second session. Our second session will focus on treating TB with digital health technologies. I'd like to welcome our two moderators for this session, Alexander Golubkov and Christian van Kalmthout. Dr. Golubkov is a senior TB technical advisor at USAID Washington, and Mr. van Kalmthout is a senior technical officer with the ASCENT project at KNCV. So without further ado, I will give you the floor.
All right, hi guys, this is Alex. Alex, I cannot activate my video. If you can do it from your end, it would be helpful. I was trying to.
Okay, sure. Let us look into that. I think it's a technical issue with the software. Thank you for letting me know, though.
All right, so good morning, afternoon, and evening to all participants, speakers, and organizers. Thank you all for joining this important and very interesting forum on digital technologies for TB. As we fight COVID-19 and TB in our countries, digital technologies are crucial tools to have in our possession, which will help us to achieve our goals better and more efficiently. In this session, we will hear from 5 speakers who will present tools and technologies aimed at helping TB patients to stay adherent to treatment for TB and for drug-resistant TB, and to finish treatment successfully. If you have any questions for the speakers, please type them in a Q&A box, not in the chat box, but in the Q&A box, as was mentioned, so we can easily navigate through questions and we can pass those questions to the speakers. So after each talk, the speakers will have few minutes to answer your questions. If we will have not enough time to answer all your questions, given the size of audience and the questions that are coming in, organizers will collect questions and then collect answers from the speakers, and then we'll post those answers and questions on the forum website. So let's start with the presentation. The first talk will be given by Mr. Eris Yoli, who is a research scientist at MIT Sloan School of Management, where he directs the Applied Cooperation team. So his research focused on altruism, understanding how it works and how to promote it. Mr. Yoli will give a talk on Kahila tool, especially on behavioral science and digital health for better TB support. Mr. Yoli, the floor is yours.
I'm a research scientist at MIT and an academic advisor to Kahila, which is a digital health startup that's building platforms to support TB patients and patients with other conditions as they undergo treatment. Today, I'd like to tell you a little bit about our actually quite long-standing collaboration. So the question, I think the big question, is the one that you see in front of you. Can we deliver a behavioral intervention to promote TB treatment success? And I think the thing that differentiates, probably, I think it's fair to say that the thing that differentiates Kahila from other attempts at providing care is that Kahila really views this as a behavioral problem. We've got a medical treatment. That medical treatment has its issues, but we've got one. And if people abide by that medical treatment, then their medical outcomes tend to be way better. If it's a drug-sensitive TB, they tend to be quite good. If it's drug-resistant TB, there's of course more issues, but even there, it's really important that people be taking their medication. There's also other behavioral problems here, like the fact that you have pre-treatment LTFU. Again, a behavioral problem more so than a medical one. So our question is, can we incorporate the behavioral science that is known out there to be able to motivate better behavior and try to use that to provide better support? The key elements of our approach are threefold, and I've already mentioned one of them. I guess I've mentioned 2 of them. One is we're going to build a digital health solution. We're going to build a solution that works in whatever technology is available to folks in sub-Saharan Africa, which is where we've been working up until now. That technology is the one you see in front of you. It's a flip phone. And so we're building platforms that work over USSD, which is a communication protocol that works for flip phones that folks are used to using because they're used to doing mobile payments. And that's the core of our technological solution. But the whole goal there is to deliver the behavioral intervention, just do it in a way that's convenient for the user. So that's the second pillar. This incorporating this behavioral science, delivering this behavioral science to the user over digital. And that's represented by this elephant, which you might recognize is the logo on the cover of Nudge, the book by the Nobel Prize-winning economist Richard Thaler. And that is the approach that fundamentally we're taking here. We're going to be thinking about why patients sometimes lack the necessary motivation to pursue treatment. And we're going to try to identify those barriers and break down those barriers using behavioral science. And then finally, we're behavioral. I'm a behavioral scientist. I have to recognize that I don't know that much about the particular context that I'm working in. And so what we're going to do is we're going to work in that context. We're going to train locals who are very aware of that context, who have experience working with TB in that context. And we're going to train them on the behavioral science and work with them together to build this intervention. That's what we've done. So those are the three core pillars of our design. Another key premise of our design is the one that you see in front of you, and that's going to be really important for understanding which behavioral science to use. And that premise is that this is not just about you, it's about your whole community. And that a big part of the reason why maybe people aren't as careful as they need to be is because they think about, curing themselves. And sometimes it doesn't feel like it's particularly worthwhile to go back to the clinic when there's a big stigma, and when you have, you're worried about losing another half day of work and losing your job, and or you have these terrible side effects and you're from the medication, but you're asymptomatic at this point and have been taking it for a while. So it feels like it's probably kind of a reasonable decision to stop taking the medication, but that's not incorporating the fact that if you do that, you will potentially harm a lot of other folks. And so what we'd like to do is get people to take that into account. And that's really our core behavioral premise, is that this is missing and that we should amp it up. There's some other stuff, but this is a key piece that you should be aware of that we're using. Here's Kahila's key features. Number one, it's a two-way SMS platform that sends a reminder and then expects a response. You get the reminder usually in the morning, please take your medication, and please, it's time to verify, please do that now. If you don't verify as the patient, then at this point, the platform will mark you as non-compliant, and in an hour, it will send you another reminder. So long as you don't verify, you'll get another reminder, a third reminder an hour after that. And then if you don't verify, then you're still marked as non-compliant. And at that point, the non-compliant folks are brought into a queue where the support sponsor, where a group of support sponsors, which is the same team that you saw earlier in the photo, are now they have access to this queue and are going to try to reach out to folks and see what's up. Why haven't you verified? Is everything okay? Do you need help with anything, etc.? And so element number one is this two-way SMS system that's a little bit persistent, and like kind of doesn't really leave you an out other than to verify. And element number two is this accountability and support that you're getting from these support sponsors. And that's really the core of this platform. There's also a little bit of other stuff. There's some gamification. There's some text messages here about like how we're all doing this together. And that stuff's also important. So these are the sort of three key things that I think make up the most important features of the platform. These features are motivated by behavioral science principles. I don't have that much time to go into this in a 10-minute talk, but you can kind of see this already if you're just reading the headlines. You can see here, if our goal is to increase observability, then making sure this is a two-way SMS system where there's actual real-life supporters is a good way to increase the observability of people's actions in a way that's actually not going to be violating their privacy, is going to be sensitive to that, but at the same time, you're going to feel like you're actually accountable to someone real. If our goal is to minimize plausible deniability, which is another core behavioral principle, then you can see why these persistent reminders and why the fact that there's no way not to verify in a given day, which might feel like it would be burdensome, why that might actually be very important. because otherwise you'll have all sorts of valid excuses like my phone ran out of batteries or my mom had my phone or whatever. So we want to make sure that there aren't those excuses. And then you can also see how we're everywhere possible, we're establishing a norm of adherence. We do that in the language that we use throughout the platform and in our communications. Those are the ways in which the behavioral science is built into the platform really from the ground up. We, in 2016, tested the platform in a year-long RCT in Nairobi involving about 1,100 patients. You see the results of that in front of you, super promising results. 13% treatment non-completion rates amongst the control group, where non-completion is taken off of the TB registers. In the intervention group, we have a non-completion rate that's well under the 5% that a lot of the development agencies are shooting for. So great news. There's some additional good news. I can just say that that result tends to hold up kind of regardless of how we cut the data, whether we just look at severe positive folks or just look at loss to follow-up rather than any negative outcome. Some additional good news is that kind of regardless of where you start out, whether you're an HIV co-infected male who is somewhat older and therefore somewhat likely to fail to adhere, then this platform tends to bring your tend to fail to complete. Excuse me. This platform tends to bring your completion rates down to about the same level. We call it the great equalizer, and I think that that's good news because it's bringing care to the folks who are really missing care. The folks for whom these non-completion rates are really high, we're able to get them to the same level roughly as everybody else. So that's also fairly promising. I'd like to tell you just a little bit about our ongoing research, and then if you have more questions, then I'm here to talk about it after this video recording. So the first thing I'd like to tell you is that we recognize that the existing RCT is small and just in Nairobi, and so we need to demonstrate this thing in a more diverse setting with more people, and we're doing that already right now. We now have a USAID funded RCT that is coming to completion in a few months. It's been about 3 years in the making. We are operating all over Kenya now. We have about 16,000 patients. I think that's about 20% of Kenya's TB population that's on the platform. So I'm a research scientist at MIT, and
all right, thanks so much. I'm not sure if we had any problems with the finishing slides, or it was how it was intended. So we have Iris with us connected. So Iris, if you would like to maybe mention a few words at the end. I think it was slides cut off. If you have any final words before we go into questions.
Hi, I hope everyone can hear me. I can't turn on my video either, so I apologize about that. But yeah, I was just covering a couple of the ongoing things that we were doing. Those include a ongoing project that is about 3 years in the making now and is coming to completion, as you heard, and that's a fairly large RCT. A second one is incorporating machine learning tools to allow some differentiated care, to try to allow us to reach out to folks who especially need care when they especially need it, to identify them and then reach out to them in ways that would be especially beneficial to them. And then the third thing we're doing is trying to incorporate the things we've learned into new platforms that would be deployed to support people as they undertake other kinds of treatment. So in particular, TBT and ARTs for HIV. And I'll just stop there since I know it's already over.
Thanks so much. Thanks so much. Dear participants, if you have any questions, please use a Q&A box and not a chat box, because Q&A box, that's for questions specifically for the speakers, and chat box is more about logistical support and technical support. So while we're waiting for questions to come in, so the first question is, maybe I can ask if what is your, I think your platform is mostly focused on drug sensitive TB, right? So what is your thinking about incorporating or maybe expanding to drug resistant TB?
We've actually supported both drug sensitive and drug resistant now in our latest study. The difference is that you have to account for, I mean, this is going to be true anytime you adapt a platform to a new treatment regimen, you have to account for differences in the treatment regimen. But the behavioral principles are the same. They just have to be, they have to account for the fact that you might not be taking their medications at exactly the same time or in exactly the same ways.
All right, thanks so much. And next question we have from a chat box. The first one is this the app-based tool, or is you only use SMS?
Kind of neither. It's a USSD-based tool. If you've never used USSD, then that might be the source of the confusion. But think about like if you've heard of M-Pesa and payment platforms, that's how it's working. It's cloud-based. So you put in a short code, and that creates a cloud session where you're interacting in real time with the cloud. It's all text-based. And so it feels a little bit like an SMS interaction, but it's actually a live session with the cloud.
Okay, thanks so much. And maybe last question before we go into next speakers, because we have 4 more and we need to squeeze into 1 hour. The question is, can patient adherence to medications be monitored somehow routinely using this technology? I mean, I guess somehow you have any dashboards or some monitoring tools for staff and managers to see what's happening with a cohort of patients?
The answer is, again, sort of. If you want to know whether somebody took their medication, then that's going to be obviously very difficult. We don't have like a blood test or a urine test in real time. We do, however, have the verification data. So whether the patient actually logged in and said that they took their medication, and that's available to folks using the dashboards. I didn't go into the back end, but it is available to folks using a back end that summarizes these kinds of metrics for healthcare providers and for our team that's doing the support.
Right. Yeah, that's what the question about. Yeah, whether the adherence can be seen. Okay. Thanks so much for your answers. Thanks so much for the presentation. It was amazing to hear about your tool. So let's move on a second speaker. The second speaker is Mr. Romano Garcia, who is a Microsoft certified professional with more than 10 years of solid experience in IT. In 2011, he was awarded a merit certificate by University Research Corporation, URC, for his excellent accomplishments and contribution in IT. Right now, he works as an mHealth specialist for USAID TB Platforms project in the Philippines, implemented by URC. Mr. Garcia will present Connect TB, novel mHealth tool to improve MDR TB treatment adherence, and from his example from the Philippines. Mr. Garcia, floor is yours.
Hello to everyone. Good morning, good afternoon, and good evening. I hope everyone is well and safe. I'm here to talk about Connect TB as a novel mHealth tool to improve DRTB treatment outcomes. I would like to thank and acknowledge my co-author and their respective organizations for making this possible. To address the problem of higher loss to follow-up rates in various countries, URC has developed a mHealth application called Connect TB. Connect TB uses technologies that are accessible and cost-effective to provide invaluable real-time insight into the quality of program performance, such as monitoring of DRTB patients on treatment, patients monitored at facility or in community settings, observe treatment and track side effects of drug regimen, contact tracing coverage, and real-time geoclustering of patients on support. Connect TB is composed of a web portal and a complementary Android application. The web portal is used by administrators to register patients, supervisors, and directly observe therapy or DOT providers, and by supervisors to review submitted DOT surveys, while the patient management Android application is used by DOT providers to submit DOT surveys and geotags. Connect TB was introduced in Bangladesh in 2013 and in June 2015 in South Africa. Seeing the potential in the implementation in the first 2 countries, URC introduced Connect TB in the Philippines on 2018 to the National TB Program and in 2019 to the Knowledge Management and Information Technology Services, or KMITS. The goal is to demonstrate the feasibility of using ConnectTV in Philippine settings. The demonstration was conducted over 6 months from January to June 2020. We sought initial approval to use the technology from KMITS to have government buy-in. We adapted the variables within the app for the Philippines context. We engaged the Antipolo City Health Office to obtain local leadership for the intervention. A baseline assessment was conducted in January 2020 to assess the facility's performance in treatment adherence. 18 DOT partners were trained to use the application. A preliminary implementation review was conducted last June 2020. A baseline assessment showed that in 2019, the loss to follow-up proportion was 16%, of which 47% were related to adverse drug reactions, while the proportion of patients with an adherence rate of 100 was at 69.5%. This table shows the reason for the loss to follow-up of DRTB patients in Antipolo City. 47 DRTB patients participated in the demonstration. Preliminary results shows an increase in the proportion of patients with a treatment adherence rate of 100 to 86%, and loss to follow-up proportion was reduced to 5%. The figure shows an increasing adherence rate of 100% when we started the pilot in January 2020. A total of 5,249 directly observed treatment was completed, and 248 adverse drug reactions were identified, managed at the facility, or referred for further management. The major factors for the successful implementation are the following. First, the promotion of intervention at various levels, starting at the national level through NTP in KMITS, regional, provincial, and municipal or city level. Since the health services in the Philippines are devolved, in which the national government vests power and authority upon local government units to perform specific functions and responsibilities. Second is the engaging of local chief executives and partnering with other USAID implementing partners and private sector for support to promote the sustainability of the program. Third is conducting continuous mentoring and supportive supervision to the facility to ensure the utilization of the intervention. Monitoring and evaluation are required to see the impact of the intervention and improve the system as needed. As for the challenges, the first is the internet connectivity issues. Here in the Philippines, we are an archipelago of 7,641 islands. We have two major telecommunications companies, Smart and Globe. However, the internet connection remains a challenge. We are looking for ways to make the system more robust in working offline. Due to the COVID-19 pandemic, local government units' resources were reallocated for its response. Hence, we conducted several webinars to promote and stress the importance of ensuring continued TB services amidst the pandemic. And lastly, like any other intervention, adaptation to new technology is a challenge. This is why we conduct frequent monitoring and supervision. One of connectivity's impact is the real-time dashboard which displays data reports that the supervisor can use to assess DOT coverage among the supportive patients. Where there are gaps, the supervisor can zoom in to identify which patients were not seen and by which DOT supporter. The next slide shows the recorded adverse drug reactions in ConnectTV. The top three are dizziness, sleep disturbances, and hearing disturbance. These are recorded during the daily DOT visit and were immediately identified, managed at the facility, or referred for further management. One of the functionalities of Connect TV is contact management and real-time and geoclustering of patients on support. Contacts are immediately identified and referred for screening and diagnosis. A heat map can be used to conduct active case-finding activities. This shows a sample of the map for illustrative purposes only. In Antipolo, 150 household members of the patient's family are monitored daily. So far, there are no presumptives and confirmed. These are the next steps and activities of Connect TV. First is scale up. We will conduct health technology assessment to meet KMIT's criteria for government uptake. The second is to expand the implementation site to cover an additional of 32 facilities. And third, to integrate with DOH Integrated Tuberculosis Information System. We will also add and introduce new features in the app as part of quality improvement. First is improving communication between labs and providers for DRTB diagnostic results. Notification for providers regarding patient follow-up and programmatic updates. And also to access key resources including SOPs, job aids, and guidelines. And lastly, map of all diagnostic, treatment, and DRTB providers available on and offline. In conclusion, the mHealth tools such as Connect TV can significantly improve case finding and treatment outcomes of DRTB patients through the real-time display of DOT information, contact investigation, timely referral, and early management of adverse drug reactions. Thank you very much for your attention. This is my last slide.
Thanks so much, Ramana, for your excellent presentation on this tool for the management of drug-resistant TB patients. We have one question, but before we go into questions from the audience, and I hope audience will type a few questions in the Q&A box. The first question from my side: Can you confirm or explain more that there's a tool that you have, the Connect TB, is actually a tool that's used by health providers, right, and not by patients like other tools? And if you can maybe elaborate maybe in a few seconds about this tool, how it works and how it's been applied by providers.
Thank you very much for that question. I hope I'm coming, you can hear me well. So as I mentioned, so Connect TV has two parts. The first one is the app itself, where we issued a mobile phone to the DOT provider, so that could be a nurse or a barangay health worker working in the facility. So when I think because here in the Philippines, our setup before that the patients can go to a health facility to get their treatment or take the medications from their home. So once they got the medication, the DOT provider will record. There's already a list of patients, and also the medications were pre-listed. So the provider will just check all of those and then record any adverse drug reaction, if there's any, and also do contact tracing of the household members. And at the same time, at the back end, the app itself is always getting geo coordinates of the location, so that we can verify where the DOT has taken place. So once all of those information were submitted, it will be going to the server. Then you can display that. So we have a website for it. It's connecttv.org.ph. So you can just browse it, and then the DOT supervisor in the satellite treatment center can view in the dashboard. So he or she has a dashboard that he can view the outright, as I presented earlier, the number of patients who have already taken their medicines for the day. And then you can see also if there are any adverse drug reaction recorded. So just in case they need to refer it immediately, they can do so. So there are also some graphs there, like of the breakdown of patient by age, by sex, and those other informations that are available in the dashboard. In addition, the system also provides email alerts to the provider at the end of the day. So just in case one particular patient did not take the medication for that day, those names will be sent via email. So the DOT supervisor in the satellite treatment facility can view and can call the DOT provider the next day to ensure that the patient will take the medication. So essentially, that's the background of connectivity.
Okay, thanks so much. We don't have much questions, sorry. Maybe one question from the audience, and the remaining questions organizers will collect and then post on the website with the answers. How do you address the sustainability of the aspect of the project of this app, consider a level of investment in financial and technology investment and issues?
For that one, so as I mentioned also, we are lobbying support from various agencies. Like, so initially we tapped the National TB Program and also KIMITS because we are planning to turn over also the system to the Department of Health eventually for sustainability. So I think initially they inquired how much the implementation will cost. So if they will be accepting the intervention, they can just include it in the budget. So that's also the reason why we're doing the health technology assessment, because that's the prerequisite from the NTP. From the local side, we are also going to the mayors. So because here in the Philippines, as I mentioned, the health system is decentralized. So the local chief executives also have some funds to allocate to support the system. So in order for you to scale up the system, you need two things. The communication based from our experience in Antipolo. The first one is the communications cost, and then the other one is the mobile cell phone itself. So for sustainability, I think that's our strategy.
All right, thanks so much. Unfortunately, we have to move on the next presentation. Thanks so much for your presentation and answers. And I will give a floor to Christian, the co-moderator for this session, to moderate the remaining talks. Christian,
thanks, Alex. We can move to our third speaker of this session, who is Fude Boima, and he works as a monitoring and evaluation officer for Partners in Health in Sierra Leone. And as part of his role, he supervises and coordinates many of PIH projects by providing data-driven programmatic support and coordination, working closely with the medical informatics team. And he will present on the MindTB project to digitize formal and informal TB care pathways in rural Sierra Leone. Fude, the floor is yours.
Hi everyone, my name is Fude Boima, Monitoring and Evaluation Officer at Partners in Health Sierra Leone. I want to use this special opportunity and occasion to heartily welcome you all to our multi-pronged intervention for new diagnosis of TB, the MindTB project. In this presentation, we are enlisting the support of digitizing formal and informal TB care pathways in rural Sierra Leone. Background of the MindTB project. The MindTB project is being implemented by National TB Program, SysMac Sierra Leone, and Partners in Health under funding from the TB Rich Grant. PIH is a social justice organization that believes in health as a human right and currently works in 11 countries, including Sierra Leone. The organization has focused on health system strengthening interventions with no particular focus on digital interventions. So when PIH started supporting Sierra Leone during the Ebola epidemic in 2014, initially, the organization also focused on such measures. Based on the non-digital health system intervention, we are able to support the National TB program to achieve 90% treatment success rate in Kono. Increased case notification approximately plus 200 from 2016. And approximately 50% of presumptive patients were referred by community health workers in 2019. However, despite these interventions, we were still missing approximately 50% of cases in Kono district, especially among women and children. For example, patients need to travel up to 5 hours on motorbike on terrible roads to get to the next facility. Because of these experiences from Ebola, a lot of patients do not trust formal care provision and thus seek care from informal providers. Our response was to tackle these barriers and bring care closer to patients. Therefore, we implemented 3 public health interventions. 1. Community-based screening through informal providers. 2. Home-based sputum collection through community health workers. And to improve on the diagnostic through gene expert testing and sputum referral throughout the district. However, while we believe that these interventions were necessary to reach more patients, we were worried about this diverse range of stakeholders on how they will be able to communicate and coordinate sputum and patients across the entire district. So the 4th digital component, an adopted version of ComCare allowing for tracking of patients across the TB care cascade, was meant to solve these. ComCare undermines TB. CHWs in Kono district has been using ComCare application for over 3 years. Back then, they used it for adherence. The initial basic ComCare model was adopted to cover the entire TB care cascade using geo and time tags. Patient personalized accounts are updated at any encounter with formal and informal care provisions, starting from community-based sputum collection, facility-based testing, to home visits by community health workers. The ComCare allows healthcare workers to effectively coordinate results and follow-ups, including contact tracing. It as well allows management to analyze programmatic as well as health-seeking behaviors. We collect paper-based information from informal providers because they are illiterate with ComCare. That is, by making sure screening information is entered by community health workers or referral. Project impact. Over 800 HIV and TB patients have been supported through the ComCare application, and 8,833 home visits recorded so far. This is a general data from ComCare, not specific to the Mind TB project. It is also critical to know that 96% of all forms are synced on a weekly basis, making the data be easily accessible. In terms of the Mind TB project impact, our initial findings state that more female presumptive for TB in the community than in the facility, and this is largely driven by caregivers, whose majority of clients are women. Coordination between informal and formal caregivers is challenging, need close monitoring, especially in challenging geographical circumstances. We realize that weekly meetings have proven critical. COVID-19 affected screening numbers as well as making patients to refuse screening, as TB has related symptoms with COVID-19. Informal providers need close clinical and data input support, including on-a-job mentorship and regular check-ins. As we continue with the implementation of the project, our next step will focus on improving the technical challenges, such as fixing up broken phones or replacing them. We will improve on the convenient power source to charge devices in this geographically challenged location. We'll focus our attention on training for users around the ComCare application. We'll as well explore different options to connect users by providing 3G top-ups to allow them connect to the internet for regular syncing of data. We'll analyze the comprehensive TB care data to understand TB health seeking behaviors of patients in rural Sierra Leone. We'll continue to adopt programmatic strategies against the background of COVID-19 by building and strengthening community engagement to close this gap. I want to thank you all for your kind audience. Thank you very much. Thank you.
Thank you, Fude, for the inspiring presentation. I don't see any question yet from the audience, but I do have a question that also popped up at the previous speaker. And that's how is it attend that the healthcare workers are sort of the core users of this app? So how do the health workers like the use of this app, and what mechanisms have you used to support the usage of the app by them? Fude, are you online?
Hello, thank you very much for the question. Hello, can someone hear me?
Yes, we can hear you loud and clear.
Okay, can you please repeat the question?
The question is, how do the healthcare workers like the use of this app, and what mechanisms have you used to support its usage?
Yeah, so generally the community health workers, as stated in the previous in the slide, they have been using the application for over a long period of time, and initially they have been using it for adherence. So in general, they love using the app, and the eHealth team, as well as the monitoring and evaluation team, has been supporting them closely to ensure data is well tracked and all necessary fields within the application or all necessary forms that captures patient information are well intact. So in general, they love using the app, and we are providing a close mentorship and training to ensure it is effectively used.
Thanks very much. I also see that there's a question from the audience on what is the incentives available for the informal providers?
Yes, so so far the informal providers are paid based on a performance-based raise. So the more screening the informal provider do, the more money he or she gets. So in general, what we do, we encourage them to screen as much patients as needed, so that we'll be able to identify more cases within the communities. So in general, the more patients are screened, the more money they get. So we are actually backing this up with a generous incentive.
Many thanks for your clear answers. If there's any other questions, please feel free to put them in the questions and answer screen. And I'm sure that we can get back to you also after this forum. I would like to move to the fourth speaker of this session, who is Professor Charlene Wei. He's a medical doctor, a public health specialist, and the Lana Chair in Global Health Policy in the University of Toronto. And he has conducted research using implementation science frameworks to change clinical practice, but also to generate impact at the policy level in areas of antimicrobial resistance, tuberculosis control, and diabetes. And in his presentation, he will discuss a pragmatic randomized controlled trial to improve tuberculosis patients' treatment adherence via electronic monitors and an app versus usual care in Tibet. The presentation can start.
Good morning. My name is Xiaoling Wei. I'm a professor and the Lana Chair in Global Health Policy from the Lana School of Public Health at the University of Toronto, Canada. My collaborators are Dr. Pandi Pasong from Tibet and Dr. Jun Hu from Shandong. They're both from the Centers for Disease Control and Prevention in China. So the topic is to improve the tuberculosis patients' treatment adherence through the electronic monitors and the app in Tibet, China. So why we want to do this work? Because we want to solve the problem of treatment adherence among the TB patients. In Tibet, Tibet is a place with high plateau. On average, it's about 3,000 meters above the sea, and it has very harsh road conditions and weather. And the population is very sparsely located in Tibet. Traveling from one place to another place normally take half a day or the full day. So it makes the patients very hard to access services. And when there's a problem, they cannot get access to healthcare providers. And of course, there's a shortage of the health providers in Tibet at different levels. As a result, the treatment adherence is very poor, and patients take their own medications and rather than be supported by somebody else as demanded from the directly observed treatment. And there's a high rate of the multiple drug resistance or TB. The objective of this project is to evaluate the effectiveness of using the electronic monitors with cloud connections to improve the adherence of new TB patients. So we're doing a multi-center parallel group randomized control trial. We target to recruit 300 new TB patients. Right now, we reached half of this because of the impact of the COVID pandemic. So the box, we call it like generation 2 electronic medical box. It's equipped with a SIM card in the cab. So the SIM card is also connected with the cloud service. When the box is opened, it will record opening, and we assume that the patient will take the drugs. So the drugs are packed according to their blisters at a daily dosage. The boxes also has a speaker can remind the patient take their drugs, and the battery can support the box without power for at least 2 days. We also design an app, so the app can enable the follow-up, can enable the VOT, which is better seen in this picture. For example, we have the video doctors as treatment supervisors. So the video doctor will know the treatment adherence of the patient. So if there's a problem, for example, the patient stopped taking the medications for at least 3 days in a row, the video doctor will connect with the patient through WeChat, and then they will conduct the VOT, the video observed treatment. The patients can also add the WeChat friends with the TB doctors at the TB dispensary level, which is at county level, and also the doctors from the township hospitals so they can ask questions, provide support, etc. In addition, the patient would receive the health promotion information from the WeChat. So in the intervention, we provide the e-monitors for patients to hold their drugs. So the e-monitors are fully functional to remind them taking the drugs and record the treatment history and the feedback to treatment history to doctors and specific patients. And the privacy is guided because only doctors can see their own patients, while patient can just see their own history. There's also WeChat connections between the patients and the doctors at various levels. We also identified a family treatment supporter for the patient. In the control group, we also provide a box to hold the medications, but the box is deactivated. However, the box will be able to record each opening, so we know the treatment history of the patients in the control group. In each group, the patients are treated according to WHO and China National TB guidelines. They go to the TB dispensary to refill their medications every 2 months. They're supposed to be a treatment supervisor. Normally, they're major doctors according to the national guideline. But in Tibet, there's not regular practice of this, and seldom these major doctors would visit a patient. So we look at the primary outcome as per treatment adherence measured at a monthly level. So we see that in each month, if a patient meets the over 20% of their doses, we term that per treatment adherence. We also look at other outcomes. For example, like the patient level percentage of total doses meets over the full treatment period. We also look at other outcomes as treatment completion rate, loss to follow-up rates, etc. We have obtained the ethical approval from Toronto and also from Tibet. We registered the trial online. In terms of implementation, we got the support, political support and the infrastructure support from the government and also from the company. And we specifically, we have lobbied the government to say that if the trial is successful, the government is willing to implement the monitors for all the counties in Tibet to improve the treatment adherence. So those are the photos of our kickoff meeting in one county, and also in terms of training, we have all the village doctors and county TB doctors come here to train the guideline. They call the guideline how to treat and support patients and how to use the WeChat and the electronic monitors. For each time, when a patient comes to, when the doctor comes to visit a patient, they can scan the barcode at the back of the box to record their follow-up visits. And the major doctors would also explain to patients and their family members regarding how to use the electronic boxes. We did interviews with patients in their homes regarding feasibility. So by now, we can see that the patient adherence to their medications have been quite successful in the intervention arm, which is like 99% of them adhere to their treatment, versus quite poor adherence we recorded in the control arm through the electronic boxes. We haven't got the data by month, so we cannot analyze our primary outcome. So which shows the first objectively recorded treatment adherence rates in Tibet, which is far lower than what we expected. So in terms of impact, this is one of the first trials to evaluate using the electronic monitoring boxes and smartphone apps to improve treatment adherence. And it also can enable VOT. So we hope that the results of this study is not going to help Tibet, but helping other low and middle income countries to adopt this innovation. We have been impacted by the COVID-19 negatively in terms of slowing down our treatment, our patient recruitment process. But the things become normalized since May 2020, and the COVID-19 situation was not severe in Tibet. They have very low number of patients. So the next step is will be complete this patient recruitment and follow-up. Thank you, and I will open for questions.
Many thanks. I think many of us will be very interested to see the full results, especially also the adherence information per month. I did see one or two questions from the audience, and the first one is on whether or not from the perspective of yourself and the others, if there are any concerns associated with patients' information confidentiality using WeChat as a communication platform. So sharing patient information via WeChat. Are there any concerns associated with that?
Hello, thank you for the question. So it's Xiaolin. So for that part, we have specific design. Each person would have different rights. For example, if that is video doctor, the video doctor can only see their own patients who is under his or her management role. And then for the other side, the TB doctors are going to see all the patients, but that will be under the CDC regulations, which are the same, that all the TB patients will be put into the TB registers into the national TB program, so which is a confidential role. So for the WeChat, there's no functions. We can export patient, anybody in this program can export patient information to outside to others, and those information are fully controlled in the back platform, which can supply the data for can be identified data to the research team, but they connect with the national TB program data, so to make sure the data linkage, etc. Thank you.
And considering that some of these patients are in the rural areas, is electricity a problem to use these monitors?
We find that there is a high literacy for using smartphones even in the remote areas. And another thing that Tibetan family usually have a quite extended family living together. So if the patient sometimes is, for example, the elders in the family, they can be helped by their relatives. Another thing is about the connectivity. So we find that the connectivity is not that bad, but sometimes you have to identify the best location for the monitoring boxes in the houses, because typical Tibetan houses would be at least 2 levels. So it would not be good to put on the downstairs. You have to find a corner in the upstairs to receive the best signal. But it works. We do not find lots of nomads in Tibet right now, because for nomads you have to take the boxes while you're moving your herds from one place to another place. But we see nowadays most of the patients are living inside their permanent homes.
Thanks for answering these questions. I would like to move to the final speaker of this session, who's Kunpam Dork, who works at the Woolcock Institute of Medical Research, and he's a data manager, and he has over 18 years of experience in building online data collection systems and for research data management as well. And he works at the Woolcock Institute of Medical Research as a data manager for tuberculosis and lung disease studies, and he will present on the effect of digital dosing monitoring upon the adherence of patients treated for tuberculosis.
Hello everyone, my name is Cường from Nguyen Cốc Institute for Medical Research in Vietnam. Today I would like to present the effects of digital dosing monitoring upon the adherence of patients treated for tuberculosis in Vietnam. So firstly, I would like to provide some background. Tuberculosis is an infectious disease that is endemic in Vietnam. A recent cohort study of over 10,000 patients with TB performed by the Vietnam National TB Program and the Nguyen Cốc Institute found the high rate of TB relapses, 6% and death 10% after patient commenced treatment. Non-adherence is an important risk factor for relapses among patients with TB. In many healthcare systems, patients are required to self-administer therapy, potentially resulting in missed doses and poor treatment outcomes. Adherence monitoring method using digital technologies has been shown to be feasible and effective in treating patients with HIV and AIDS. These technologies may enhance treatment outcome in Vietnam, where we have 78% of the TB patients on their mobile phone and 95% of the population live in the area with 3G mobile phone coverage. In this study, we evaluate the effect of digital adherence support using a medication event reminder monitor, what we call it MERV, for our patients treated for newly diagnosed with smear-positive pulmonary TB in Vietnam. For the study method, in this study, we use a parallel randomized control trial was conducted among 250 outpatients with newly diagnosed smear-positive pulmonary TB treated in Thanh Hóa province in Vietnam. Thanh Hóa is a middle province in Vietnam. The duration from the August 2017 until January 2019. The patient in the intervention arm were provided a MERV box equipped with a daily alert when a dose is due. So here you can see some picture of the MERV box. In this area is the medication storage, and this one it reminder SIM card and battery compartment in there. And at the bottom of the box we can see the reminder last line with 3 colors. When enrolling link patient, we ask that for the time they often to take the daily medication and report it in the system. So every time when the patient opens the box to take the medication, the system will record the signal and send to the cloud server. So in the management interface, we can manage by each participant and by each day and by arm. For the exclusion criteria, the patient with newly diagnosed microbiological confirmed pulmonary tuberculosis, taking only standard oral therapy for TB. They are our patients. They have at least 4 months of treatment remaining. They are over 15 years old. For the exclusion criteria, diagnosed with MDR TB prior to enrollment, a history of prior treatment for TB before the current episodes, severe mental illness. So adherence data collected by the device was used to consult patients about their adherence during the following month. So every time we receive the information when they take the drug, we receive the signal into the cloud server. So we use that to counseling patient about the adherence. The patient in the control arm receives standard self-administered therapy delivered in the merge box without alarm. Outcomes included the proportion for individuals with adequate adherence we define as missing less than 20% of dose per month, less than 20% of dose per month, and treatment outcome. And here this slide will show you the result characteristic of the patient enrollment in our study. So there are 124 intervention participants among 250 participant recruitment. So 84% are male, and the median age at enrollment time is 48.8. Some information about the smear test result. We have nearly 60% of participants have the positive smear test, and about the check history result, 92% of participants has check history result with the consistent with TB. This slide will show you the proportion of patients with TB with adequate adherences. So you can see, as you can see in the fingers, the red line will be shown for the intervention group, and the for control group will be shown as the blue one. So you can see in the first month the adherence rate among both arm intervention and control arm is quite similar. It's around 87%, and started declining from the second month. And for the from the third month to the fifth month, the intervention was associated with a 14 to 19 increase in the adherence compared to the control arm. And for the last month, in the 6 months, the different rate is the different in the adherence rate were 11%, almost 69% for interventions, and 97% for control arm. So requirement for implementation, because we need the political will and the government buy-in, physical and human resource infrastructure. We need the budget and the procurement. Because we're using the merge box technology, so we need to technical support, IT and data needs. In my conclusion, I would like to say the use of the digital daily reminders coupled with individual patient counseling improve adherence among patients with tuberculosis. Treatment adherence was poor at the final month of treatment. You can see in previous figure, the adherence rate at the 6 months is low. Lower level of adherence was not detected through routine treatment outcome reporting. So that's all of my presentation. Thank you.
Thank you so much. I do see that we have to limit our questions to 1 or 2. I see there's one very good question from the audience. Is there any significant difference between the intervention and control as defined by your outcome?
So there was no difference in reported treatment completion between the two arms. Okay.
I was looking at your graph at the adherence rates also in the last month. So do you have any explanation for that 10% decrease of adherence even in the intervention group in this the last month of treatment, the 6 month of treatment, where it dropped from I think 68 to 58%?
Actually, we at the end of the treatment, we have the questionnaires, the online surveys to ask them how do they use the box and ask any reason why they didn't use the box anymore, and why it's explained how the rate is low than the other month. So the explanation it could be say so they have some better health and maybe they sometimes they miss the take time to take drugs. So and that means they have to have no signal in the system. That's why they have explained the low rate at the last month.
Yeah. Thanks. With that, I would like to thank all of the speakers in this session that presented on the 5 different approaches on how digital innovation can support TB treatment and care. All these questions that you have all questioned as an audience were captured by the organizers. So if you have any other question, please feel free to add them in the Q&A. And I'm sure that the organizers make sure that questions who couldn't be answered today will be answered at a later moment. And as said by my other moderator, Alex, before, that in contrast to all the new challenges that are imposed by the current COVID-19 pandemic, we believe it also presents an opportunity to elevate the focus of virtual modes of TB treatment and care, and that the pandemic may serve to expedite the willingness of countries and funders to prioritize decentralization of care and using these digital technologies. And these readily available tools for patient support, such as the ones that were presented in this session, can hereby help ensure that the health and well-being of TB patients continues to be prioritized. And with this, I would like to end this session. And thanks again for joining. And please stay with us for the final session of today.
Thank you very much to all of our speakers and to our moderators for this session. I'd like to move to our final session for today, which focuses on preventing TB with digital health technologies. And for this, I'd like to welcome our 2 moderators, Savim Ahmedov and Jacqueline Ha. Dr. Ahmedov is a senior TB technical advisor at USAID Washington, and Ms. Ha is the head of external affairs and strategic initiatives at the Stop TB Partnership. So without further ado, I'd like to welcome both of you to take the microphone.
Thank you very much, Alex, and it is a pleasure to co-moderate this session with my distinguished colleague Jackie Ha. I see that we are running a little bit late on the agenda. So I would like just to say and highlight the importance of prevention of tuberculosis, following up the excellent sessions from this morning. I think just like with treatment and care, the digital health technologies have a big role to play also in prevention of tuberculosis. The main objective of this session is to really share some very excellent examples from diverse settings from South Africa, from Nigeria, and Uganda, how digital technologies and digital approaches can be applied to real life situations. As you know, TB prevention is a consists of a very broad and quite complex set of interventions, from interruption of transmission of infection and disease, to halting the progression from latent TB infection to active TB disease, as well as a broad range of interventions under infection prevention and control. And as the audience is also aware, under the UN high-level meeting targets, the countries adopted very ambitious targets that also include placing 30 million individuals on TB preventive treatment. And unfortunately, prevention of that target remains, the progress on that target remains the least attainable so far under the UN high-level meeting high-level meeting targets. So it is definitely this digital health and the approaches on the digital health do provide us with opportunities to be able to accelerate the progress on those targets. Without further ado, I'll also turn it over to my colleague Jackie to introduce the presenters and the session. Thank you.
Thank you very much, Savim, for your remarks and for setting the scene so nicely for our session. A good day to everyone who is joining us from across the world. It is a real pleasure to be with all of you. Before we dive into the program, let me just note that after each presentation, there will be a 2-minute Q&A session. During the presentation, if you have any questions, please enter them into the Q&A box, which Savim and I will facilitate accordingly. For questions we cannot get to, our event organizer will compile them, share them with our speakers, and then with the attendees. So with that said, let's finally get this show on the road. I have the distinct honor of introducing the speakers for our session, and hopefully all the research and practice and making sure I correctly pronounce our speaker's name will hopefully pay off. With that said, I would like to extend a warm welcome to our first presenter, Dr. Masie Mapatale, who is the Infection Prevention and Control Advisor for URC's TB project in South Africa, and her presentation will be on IP Connect. So if we can play Masie's presentation, please.
Good afternoon, good morning to everyone. In my presentation, I will be sharing experiences and lessons learned on implementing a digital platform for improving TB infection prevention and control in healthcare facilities. IP Connect is a zero-rated digital platform that runs on both web and phone app, which was launched in South Africa by the National Department of Health in 2017. By zero-rating the platform, this means the user is not charged for using the app, but connectivity costs are covered by the owner of the app. This digital platform aims to improve infection prevention and control in the facility setting. It also aims to strengthen occupational health by making sure the services are accessible and support is given to infected workers. It aims to reduce the risk of TB infections and allows healthcare workers to gather and analyze data for more targeted IPC interventions. The platform allows users to track and implement risk assessments in health facilities and has the modality to monitor environmental controls using carbon dioxide monitors. The platform is currently implemented in 14 districts across 6 provinces, that is the Eastern Cape, Free State, Gauteng, KwaZulu-Natal, Limpopo, and the Western Cape province. The platform has various functionalities and roles, the first being the user interface role, which is implemented by the general user to conduct risk assessments and monitor CO2 levels. The second is the administrator or supervisor role, to view, analyze, and support implementation. IP Connect is made up of several modules, which includes national guidelines on TB management, M or XDR TB management, infection prevention and control, and other diseases. Risk assessment module, which is a questionnaire for primary healthcare clinics, is adopted from the national tool. The tool looks at the level of compliance with standards relating to admin and environmental controls, including PPE, infrastructure, and staffing. This allows healthcare workers to analyze and determine appropriate ways to eliminate potential for risk. The user can view different cycles, work on a new assessment as shown in the figure below. The CO2 app is for monitoring environmental controls and consists of two parts. The monitoring dashboard, of which at a glance will show the number of alerts, alarms, and average CO2 concentration level in the last 4 hours, and the reporting module. How this app works is that it pulls raw data from the CO2 sensor server in intervals and store in the IP Connect database server to further process and disseminate to the users of the IP Connect web portal. The platform is implemented in the 14 project-supported districts across 6 provinces. In year 2 and 3, the target was 200 facilities, and coverage was 95%, 73%, respectively. In year 4, we achieved 48%. The app has a functionality to view assessments completed per cycle. It also displays real-time data with regards to compliance with IPC controls in each section, which is graded as achieved, partially achieved, or not achieved, as per the figure below. The risk assessment app can flag areas for follow-up and has a functionality to print reports, which is important for planning and allows the IPC team to make decisions regarding the focus of the IPC program. The dashboard for the risk assessment can be customized as required. The user can select preferred province, district, and assessment cycle. The figure below shows effectiveness in monitoring IPC compliance coupled with mentoring of healthcare workers over time in 30 facilities across 10 districts. Healthcare worker TB screening program improved from 35% in 2018 to 53% in 2019. Facilities having IPC plans also improved from 15% in 2018 to almost 70% in 2019. The CO2 intervention is implemented in 9 hospitals across 5 districts. The CO2 app has 2 modules, monitoring dashboard and the reporting module. The figure on the top right-hand corner is an example of the parameters for monitoring of CO2 performance on IP Connect. At a glance, it gives you the number of alerts, alarm, and average concentration level in the last 4 hours. The reporting module shows the list of districts, clinics, and location of CO2 devices and facilities, and the CO2 concentration levels, which triggers alerts or alarms. When CO2 threshold is exceeded, healthcare workers are alerted via SMS to either improve ventilation or decant the affected areas. Data can either be presented in a graphical mode or table format. Through use of IP Connect, we have been able to monitor IPC practices, and the graph below shows CO2 concentrations from casualty on the left and OPD department on the right in one of our hospitals, that is OD Hospital. CO2 data from casualty shows elevated levels of CO2 when it is busiest in the afternoon and evenings on weekdays, which means the ventilation is compromised and the risk of transmission is high. OPD was busy daily between 8 and 10 a.m. with the CO2 levels briefly exceeding the safety limits. The requirement for successful implementation of IP Connect include political will and buy-in from government, facility management, and healthcare workers. Access to IP Connect applications is based on staff needs, duties, and of course will vary by application. Use of site requires internet connectivity just to log in into the browser. However, the user is not charged for administering the app. Risk assessment application is also available to users on the Google Play Store. Users have the ability to work offline and upload to the server when internet connectivity is available. IT support for application upgrade, monitoring, and maintenance is also required. In terms of cost, there is one-time cost to set up the system. The only cost per user are tablets, smartphones, and data. This section focuses on impact of IP Connect on prevention of TB transmission at facility level. One of the benefits that we have seen is that facility managers are able to look at both real-time risk assessment data, CO2 data, historical trends, and develop operational plans and targeted interventions for problematic facilities or areas. Graph on the right is data from 11 facilities in Cape One Lands. It shows an improvement over 1 year period by 24% for facilities with IPC plans and 18% for facilities with guidelines after providing and training staff on guidelines. Feedback shared from our unstructured interviews with infection control personnel concerning the use of IP Connect showed enthusiasm to conduct annual risk assessments since implementation. This is evident in the increase of risk assessments conducted in each district between 2018 and 2019, from 1 to at least 3 per month. The users have also reported that the app is easy to use and also saves time. In conclusion, we plan to expand access to all managers at all levels, that is at district, provincial, and national level, in order to be able to monitor the progress made. Expansion will also include a module for risk assessment in community settings. The next step is to grant access to the National Department of Health. Currently, the project has administrator rights, so we will assign administrator rights to colleagues at national and district level. We will also improve access to facilities directly supported by the project for better coverage and boost the security system. As with any app upgrades, we need to ensure that the system is secured. We need to ensure that it is stable and safe from any threats. I thank you.
Thank you very much, Masie, for your really informative presentation. So I actually do not see any questions that have come through, and I hope people are not shy. But Savim, I don't know, do you have any questions for Masie? I do, but I'm a little bit worried that I'm probably asking too high level of a question. So I don't know if you have any questions, Savim, for Masie before I ask mine.
Yeah, thank you, Jackie, and thank you, Mati. Great presentation as always. Maybe just one quick question. I see that you have the web link for other countries or other colleagues who might be interested in this. Maybe just a quick reflection of how easy and feasible it is for this to be replicated in other countries and in other settings. Thanks.
Hi, thanks, Savim, for the question. It is quite easy. It is available on the web, and I also mentioned somewhere that it is also a phone app. So for Android phones, you will be able to access the app. So with other countries, I think the key thing is IT support in setting up the system. And in terms of the user, there isn't much because you just administer the tool. So the key thing is setting up, getting the license, and yes, you're good to go.
Great. Thank you so much, Masie. You know, in the interest of time, I think what we will do is actually move move on to the next presenter, and I will provide my question to the event organizer or reach out to you directly. If we can actually move on to our second presenter, I would like to welcome Habib Akande, who is actually the Strategic Health Information Specialist at ABT Associates. And he will be presenting on a new acceleration towards digital health technology, COVID-19 and the TB START application. If we can kindly play Habib's presentation, please.
Good day all. My name is Akande Habib, the Strategic Health Information Specialist on Sustaining Health Outcome through Private Sectors, SHOPS Plus, a USAID TB project currently operating in Kano, Lagos, and expanding to 14 other states in Nigeria. Nigeria is one of TB high-burden countries in the world. This is largely due to high incidence of TB cases and low TB case finding. One of the strategies to overcome this is by intensifying screening and notification. In 2019, SHOPS Plus developed and launched a screening and notification mobile application, TB Screening and Tracking for Accelerated Referral and Reporting, TB STAR. This application supports TB screening, patient referral, lab diagnostics, result transmission, process management, and data collection for strategic decision. Prior to COVID-19 lockdown in Kano, the program team emphasized that there will be low screening and reporting of TB cases due to restriction in movement, and opt for TB STAR for continual screening and notification. TB STAR, a network digital solution comprising of all types of healthcare providers. The solution uses a hub and spoke approach to relate with one another in managing screening and notification. The non-traditional TB service provider, that is, community pharmacies, patient proprietary medicine vendors, and the standalone lab, act as the spoke. The community pharmacies and patent proprietary medicine vendors, who are mostly the first point of contact for patients, use the application to screen patients and refer to the laboratory for testing if presumptive. Peradventure, if confirmed positive, they will be referred to a treatment facility. On the other hand, the laboratory screen patients that comes for other tests. If presumptive, test them in their facility and refer them for treatment if confirmed positive. The clinical facility also use the application to screen patients at all service delivery points, refer for testing if presumptive, and place on treatment if confirmed positive. They also accept treatment referral from the spoke facilities. The lockdown prevents the collection and screening of patients for TB in over 1,000 facilities across Lagos and Kano, where the project is operating, due to the restriction in movement. TB STAR comes in handy for this service provider to screen digitally the patient that comes to their facility. The program intensifies training by training 60 additional providers to the existing one prior to the lockdown, and from the outcome during the lockdown and after the lockdown, we will see from the first graph that 13 users were registered as of March 2020. But during the lockdown and after the lockdown, it increases to 106, 156, and 179 consecutively. Also, the number of screening and presumptives identified increases rapidly from 3 in March to 1,194 in April. The same thing applies for the presumptives that are increasing from 0 to 383 in April. During the requirement analysis and gathering for this, while designing the application, the field users were brought in for a meeting in order to get them involved and get their perspectives in terms of what works on the field and what works not. We were able to gather experience for them in terms of the process flow for the application according to what will work for them when they start using it on the field. We also engaged the national and the state TB program and other professional associations who will use the back-end data for decision making. The application is based on Android phone compatibility and we intend to scale up to iOS. This application is also have offline feature for those in network constrained area. The application was initially developed by international partner, which will transit to a local partner for sustainability and affordability. Technical supports and refresher training are provided remotely and follow up through SMS by the technical specialists. As of June 2020, 293 private providers were able to register on the platform with about 3,000 plus patients screened, 1,000 plus as presumptive patients, and 53 cases were reported between April to June 2020. Majority of these screenings comes from the non-traditional TB service provider that were closer to the patients during the lockdown due to COVID-19 in Kano and Lagos. The application also have a back end that displayed real-time data for strategic and decision making by the program staff.
So I think we might be having some technical difficulties with the presentation.
After a month during COVID-19 lockdown, we discovered that the users find it difficult to differentiate between COVID-19 and TB symptoms. We are currently integrating COVID-19 screening tool into TB Star to help the providers distinguish between COVID-19 and TB symptoms and continue the use of the application for TB screening. We are also training providers in the 14 expansion states to scale up the use of the application by private providers in other states. We provide real-time technical support and issue resolution using different social media platforms and quick response to the application feedback messages to ease the use of the application by healthcare provider. The application data portal support the national TB program, the state TB program, and other implementing partners. program team to manage the screening cascade reports and respond to stagnation in the screening and notification process, such as patient or sample referrals not updated in 72 hours, and confirmed patients not placed on treatments in 72 hours. We will appreciate the support of stakeholders in scaling up the application to all public and private healthcare providers in Nigeria and institutionalizing it as a national screening and notification tool. Thank you.
Akande, thank you very much for your presentation. We have a question from Mohammed Kabria. Mohammed, you're my new best friend. Thank you for your question. So Akande, Mohammed's question is, although the data shows the usage has increased since the lockdown started, it shows again the downward trend, right bar chart. What is the strategy to enhance the use of the system?
Okay, good afternoon, good morning all. So actually the downslide in the use of the application was due to the confusion between COVID-19 screening and TB screening. And a lot of patients started running from screening where they discovered that the questions are similar. They thought they were screening them for COVID-19. So what we intend to do is to integrate, like I said in the presentation, TB screening tool, COVID-19 screening tool into application so that they will know that we are actually screening for TB, and this a different question for TB and a different question for COVID-19. We are also looking at a sponsored data package. They are actually using their data. So we are looking at a situation where we have like a pool of data and people will be able to access the application whether they have data or not. And we are planning on incentivizing the comparison between the paper-based and what they enter on TB Star.
Great, thank you so much, Akande. And Mohammed, if there are any further clarifications you would like to have, please feel free to enter them into the Q&A box, and we will make sure that we get that to Akande for him to provide any clarifications in written form. So with that said, let us move on to our final presenter. Last but not least, I would like to extend a warm welcome to Dr. Louis Henry Kamulekeya, who will be presenting on lessons from using a telehealth platform for treatment linkage and here support for TB patients in the Lengo sub-region of Uganda. If we can play Louis's presentation, please.
Morning, everyone. I'm by the names of Dr. Louis Kamulekeya from the Medical Concierge Group, a digital health company headquartered in Uganda, East Africa. And I'm here to present the lessons learned from using a telehealth platform for treatment linkage and adherence support for tuberculosis patients in Nango sub-region. The innovation is a telehealth platform that supports tuberculosis prevention and treatment. It was started in 2019 and currently is being used by a USAID-funded project known as Regional Health Integration to enhance health services in North Lango, Uganda. This project is a district-led activity which is implemented by a consortium of partners led by John Snow Inc., with partners including the Medical Concierge Group, TMCG, AMREF, Another Option, and Quam Doctors for Africa. The digital health platform responds to prevention, care, and treatment for tuberculosis needs within the sub-region. And it includes a 24/7 telehealth center, which is manned by medical professionals and responds to beneficiaries' inquiries via voice and SMS platform, in addition to remotely resolving inquiries that come through these different platforms. In addition, the TB patients are supported with health facility reminders upon consulting that helps in treatment adherence and honoring of facility appointments. And also they have access to health content that traverses different topics, including addressing myths and misconceptions, awareness about possible side effects of medications that they're taking, TB medications that they're taking, and also content on nutrition as it's an important integral in TB treatment. The USAID Red.Lango region is mid-north, as you can see in the slide. It's between the extreme north and the central region, and that's where the 9 districts that make up the sub-region are located, and that's why we are supporting the region, the project. It's relatively rural in setting. It's away from the central region, Kampala, which is the capital city. Access to mobile is about 50% of the population, and basically we're looking at a suburban rural demographic that we're supporting. The intervention is, as you can see in the platform, as you can see on the slide, it's a voice call platform workflow, where through either posters, through stickers or pocket cards that have the project toll-free line get to be distributed to target beneficiaries, either through community activities or at facilities where these cards or posters are pinned at strategic places like the TB screening area or the art care clinic. So beneficiaries are able to call in, as you can see in workflow 1, and the doctor at the call center remotely able to address their questions or inquiries or clarifications through flow 2. And at the same time, the doctors have to record the encounter that they are having with the patient in the call record system, which then is integrated with the database, which can be retrieved secondary for analysis, studying trends that may involve informing on changing on interventions that are happening at the facility. The SMS workflow, as you can see in the slide, involves 2 ways in which beneficiaries benefit from the SMS. First, it's through the automated system that beneficiaries can access health content through campaigns. This involves using open source software called Rapid Pro, where content on varying topics, including awareness about TB signs and symptoms, all this content goes through that kind of content development and approval. Final content, which can be translated into the local languages, is uploaded onto this SMS platform, and then beneficiaries can access it through sending a keyword like, say, SMS the word TB to the shortcode of the project 8884, and that's through workflow 1, and they're able to get automated response through workflow 2. However, some beneficiaries may opt to send their inquiries through SMS instead of voice, and the telehealth center, which is manned by health professionals, will provide that case by case response, and that's where the platform called Case Pro comes in, which is uniquely an open source software, but is uniquely designed to serve the needs of the project. So you find that an inquiry goes through flow 1, then because it's a question or inquiry, goes through then flow 2 on the other side of the telehealth center. The doctor responds through flow 4, and then the target beneficiary will get their response through flow 2. What have been the results? The intervention has been taken up in all the 9 districts of the sub-region, including Aleptong, Amlata, Apache, Dokolo, Kole, Oyam, Otuke, Kwanya. And from the time period of inception, that is in October 2019 to July 2020, 417 TB clients from 58 health facilities have been supported with appointment reminders. 10,233 beneficiaries have been supported through community awareness TB SMS campaigns, and 1,120 TB related voice call inquiries have been resolved. And majority of these inquiries have been on medicine use, how to manage side effects from home, isoniazid preventive therapy, and access and screening of services. We have done assessment surveys. We did a dipstick assessment survey to assess adherence to appointment reminders among supported health facilities, and we saw that from 2019 to 2020, there was an increment from 65% to 89%. To implement this intervention, there is need for certain requirements to be made. From the political and government buy-in, there is need for, say, licenses of our professionals, that is the health workers, and also licenses from entities or stakeholders that manage information technology in Uganda, like the Uganda Communications Council and among others. In addition, policies and guidelines that govern interventions like ours, for example, the e-health policies, and also in-house to support our processes, we've developed standard operating guidelines that help to improve adherence to standards. In terms of physical and human resource infrastructure, you need the health professionals, data scientists, software engineers, quality assurance team to help in improving the standards of processes, and of course the servers and call center workstations. The budget and procurement will basically depend on your target users, the duration of the implementation, the complexity of the technology platforms to be used, and of course the extent to which you want to be interoperable with existing national systems. In terms of technical and IT data needs, you need, of course, licenses for the softwares that you're purchasing and utilizing, including, say, if you're going to use an SMS short code or toll-free hotline, like in our case, or internet, and of course, stable and backup power supply, especially in our settings where power may not be very reliable. What has been the impact of the intervention? The intervention has helped to improve health information dissemination on TB at a scale. This is through diversifying the channels of communication from the traditional print and media. And also the potential for improved clinical outcomes, where provisions to have remote resolution of inquiries in real time rather than visiting health facility physically, and consequently resulting into delay in addressing complaints that often results into poor adherence and hence development of drug-resistant TB. Then also the potential for the platform to be used by health workers, especially local health workers, to remotely consult with higher cadre health workers remotely, hence acting as an extension to hospital-based care. What are our next steps? We're mainly going to focus on an increased uptake and adoption of the project among other target beneficiaries. In addition, we want to interest other public health projects and implementing partners to adopt similar approaches like ours in TB and other health programs like, say, maternal nutrition and child health, HIV care, among others. We also want to do some studies that assess the nuances of adoption and uptake of digital services in TB care. And also we want to develop more automated means of leveraging technology, especially when you're looking at, say, artificial intelligence and chatbots for information dissemination, and also self-administered screening questionnaires, because this is how we think digital technologies can be adopted at scale. Thank you for listening. Have a nice day.
Louis, thank you very much for your presentation. And I can't tell you how I got excited by it, because it's something, telehealth is something, at least personally, I'm very passionate about. So I think, just to very quickly answer Aubrey's question, yes, all the presentations from the event will be shared. If I'm not mistaken, it will be posted on the event's website. But Andrew, going to your question, which is, have there been any attempts to compare the improvements in adherence among supported clients to those receiving the standard of care? If so, has the intervention proven to be significantly better compared to the standard of care? And Louis, I might actually tack on something that I would really love to ask as well to Andrew's question, which is, I feel like the beauty of a telehealth platform is that it can run across the care model, not just on adherence. So I was wondering, in addition to Andrew's question, how the telehealth platform that your organization has developed could actually provide quote unquote care across the entire care model, from prevention all the way to post-treatment care. So Louis, the floor is yours. Louis, are you here?
I don't know if I'm audible. Am I audible?
Oh, yes, I can hear you. I can hear you now. Yes, please go ahead.
Thank you, everyone. To address the two questions, the first question on whether we have tried to compare our intervention versus the standard mode of care. We haven't yet, and that's one of our next steps, to make such comparison, especially within the same supported health facilities within the same, say, region or district. We want to see how does our model in supported health facilities compare with other facilities that are getting the standard care in terms of no telehealth support, just the usual? We haven't yet. That's one of our next plans. As regarding to the question on how have we, or how can telehealth be integrated across the entire journey from, say, prevention, care and treatment, retention and care, up to the entire cascade of TB treatment. What we have done is that we have looked at how the different aspects, especially, say, SMS or text-based platform and voice call platforms, could be integrated across the entire cascade. So what we have done is that on the prevention arm, we have mainly leveraged on text-based platform, so generating content, developing it and disseminating it, leveraging SMS, and then leveraging still automated methods of response, such as artificial intelligence algorithms, and also SMS for automated response for prevention arm. And then in terms of care and treatment, linkage to services, and rotation in care and completion of TB treatment, we have used both the SMS, so the text-based platform, that is SMS and chatbots, but also the telehealth center, the 24/7 call center, where we have these. It's manned by doctors, and so I saw a question on why the SMSs or inquiries are responded by doctors rather than nurses. The current health cadre that we're employing are doctors. So of course, because of task shifting, we anticipate that we can always train and have other health workers take on such responsibility. So we have this 24/7 call center manned by doctors that respond to, that provide this remote support in terms of remote resolution or teleconsultation with the patients. But also at the same time, we do periodic quarterly voice call follow-ups to see who did not honor their appointments, who honored their appointments, what were the reasons why they didn't honor appointments, and how can we overcome that? So that's how I would respond to that question.
No, Louis, thank you so much for your answers. And I'm sure there will be a lot of people reaching out to you after this event. So I just want to thank all of our speakers and the 164 participants who have powered through this event with us together. Now that we have heard from our three fabulous speakers who provided like some really thought-provoking presentations, and what I really loved about everything I've heard today is how many innovations and new ideas are coming from the TB-affected countries. And I think that is a really, really, really great sign. So now I would like to give the floor back to Savim for some very brief closing remarks and his wise words. He's kind of like Yoda to me. So Savim, the floor is yours.
Thank you, Jackie, and my sincere also appreciation to Matsi, Habib, and Louis for these excellent and outstanding presentations. It's really, Jackie, you articulated it extremely well. Having the diverse solutions that are coming from situations in countries that have very high burden, unfortunately, still of tuberculosis and HIV and other comorbidities. It's great to see how we can harness the creativity of these digital health approaches and digital health interventions to help us fight a very ancient disease. So it's great, really, through all the presentations to see the focus and the emphasis of how do we monitor the impact of these interventions. I know that we still do have a lot of skeptics out there that are questioning the effectiveness and how well these new technologies can help us in the fight against tuberculosis. So I really, my hat is off to every single presenter who brought the data and the evidence to show the impact and the potential for impact of these interventions. TB, unfortunately in TB, as we all know, there's not one intervention that can solve all of our problems. There's no, as they say, killer app that we can employ tomorrow and get rid of tuberculosis. We do need diverse tools in our toolbox to be able to tackle this complex disease. So thank you again to everyone, and thank you to the participants. Thank you very much, Jackie, for moderating the session. Thank you to the organizers, and again, special thanks to the presenters. Over to you, Alex.
Great, thanks, Savim, for the thoughtful comments there. And I'd like to echo the thanks and congratulations to all of the presenters today. With this, we've arrived at the end of our first day. I'd like to again thank all of our speakers, moderators, presenters, and I'd like to thank all of the participants for joining us. Today, we've explored digital health technologies for detection, treatment, and prevention of TB, and we've laid the groundwork for understanding the state of technology for TB. Tomorrow, we're excited to focus on private sector innovations, data analytics, and a real-world implementation panel in which we will discuss these topics with NTP leaders. We look forward to welcoming you tomorrow, and we hope in the meantime that you'll have time to check out our poster presentations and supplemental material, which is posted on the forum website. So thank you again, and we look forward to welcoming you tomorrow.